Good morning, everybody, and you're very welcome to this EBUS live virtual course sponsored by Olympus. We're very grateful to you all for joining. Let me begin this morning by doing some introductions. So my name is Dr. Neal Navani. I'm a consultant respiratory physician at University College London Hospital, where I'm lead for the lung cancer service. I'm being joined this morning by two esteemed colleagues, Professor Robert Rintoul, Professor of Thoracic Oncology at the University of Cambridge and consultant respiratory physician at Royal Papworth Hospital, and my close colleague, Dr. Ricky Thakrar, consultant respiratory physician at University College London Hospital. So it's great to have you all joining us. A few bits of housekeeping before we get into the meat of the course. So this course is being recorded by Olympus and will be available on their platform for the next 30 days. On your platform, you should be able to see a panel that will allow you to answer some polls that will appear at various points in the morning and also allow you to submit questions. We really do encourage you to make this as interactive as possible and submit as many questions as you can. And then the final bit of housekeeping is that we're planning a break for you to have a cup of tea and stretch your legs at about 10:35 a.m. So I'm really pleased to hear that there are about 66 delegates registered. This has been a long-standing EBUS course. It's been going for over 15 years. That Olympus and Robert initially helped to set up. I remember attending it myself around 15 years ago at Robert's Institute at the time at Papworth. So it really has been a very successful course. Obviously, in the last couple of iterations, we've moved to this virtual platform. So really do appreciate your feedback on the on all aspects of the course. In terms of areas that we're hoping to cover this morning, we're going to start with an introduction to EBUS from Robert. I'm then going to take you through some of the mediastinal anatomy, and then we're going to have a live procedure. I say live, but obviously recorded procedure that Robert did, and there will be some commentary over that to talk you through the procedure. We'll then have an opportunity for a Q&A during after that first live procedure, and that will take us up to the first break at 10:35. We're then going to come back at 10:50 promptly to have a couple of talks, again from Robert and Ricky, on the role of EBUS before we move to the second recorded case. We'll then have an opportunity for further questions about those talks and the second case before we aim to wrap up and close before 1 o'clock. So that's what we're hoping to deliver this morning. As I say, we do want to make this as interactive as possible, so do participate in the chat and the polls. So let me then now hand over to Robert to deliver the first presentation, what is endobronchial ultrasound, and take us through some of the real fundamentals of EBUS. Robert, over to you.
Thank you very much indeed, Neil, and good morning to everyone who's out there listening. This first talk is about what is endobronchial ultrasound. So first of all, my disclosures, which I'll just let you look at for a moment or two. Now, what I'm going to do initially is just ask you what your experience of EBUS is. So this is the first poll. There's only one poll in this talk. It just helps me get an idea of the sort of range of experience out there. So I can see already that it's coming up predominantly with assisted with cases, 80%, and there's a little bit of a lag there. Okay, so a few of you have got some theory only experience. Some have watched some cases. Most of you have assisted with cases, and we've got some who, in fact, are independent practitioners. Great, that's really useful. Thank you very much. Okay, I'll move on. So, what I'm going to cover in this talk is these objectives. The time before EBUS, before we had EBUS, the different types of endobronchial ultrasound. This course is predominantly about linear endobronchial ultrasound, but I'm just going to touch on radial EBUS as well, which some of you may know a bit about, but others may not. Then we'll just look at how some of the basics about how the EBUS scope works. I'll then just touch on some basic anatomy with lymph node stations, which is going to be expanded in considerably more detail by Neal in his next talk. And then a little bit about how we do EBUS and how we set up our room. And then finally, a brief introduction to EUSB, which is using the bronchoscope in the esophagus. So, Olympus was the first to commercialize linear EBUS in about 2006, 2007. And prior to that, we had radial EBUS for about a decade. But in fact, before that, before the era of endobronchial ultrasound, we only had non-ultrasound guided transbronchial needle aspiration, sometimes called Wang biopsies, where essentially you identified your lymph node of interest on a pre-procedure CT scan, as you can see here in the inset, a very large subcarinal lymph node mass. And you went down with a standard bronchoscope, with a 2mm channel probably, and then you used a needle which you passed down the working channel, and you pushed it through the airway wall between the cartilage rings into the area where you believed the lymph node was, and then tried to aspirate whatever you'd gone into. And this worked quite well for big subcarinal lymph nodes where maybe the carina was splayed, but it was more challenging in other areas. And essentially it's limited to nodes which were quite large and adjacent to the trachea or main bronchi. And not surprisingly, it was very operator dependent. Those people who did a lot of it got quite good at it if they selected the right cases and the right lymph node stations. But as you can imagine, there was very variable tissue yield related to the experience, as I said, and the size of the lymph nodes and the nodal position. So when Holty, who published in Thorax in 2005, looked at this, it was not surprising that he found that there was a considerably variable sensitivity for detection of malignancy. If you had on-site cytopathology, so-called ROSE, rapid on-site cytopathological evaluation, that helped because you had a cytopathologist or a technician saying, yes, we've got malignant looking cells or not. But that was, again, quite laborious and involved. And there were also, many people had concerns about possible complications of doing these procedures. What if you hit a blood vessel? And what if you cause bleeding? Although actually the reported complication rate was pretty low. But as with all these retrospective case series, which invariably they were, the complication rate reporting is variable. as I said, in good in experienced hands, it could be used for in a diagnostic setting, for instance, biopsying that big subcarinal lymph node mass, but this approach could not be used for systematic staging. So then we move on to endobronchial ultrasound. And as I mentioned a moment ago, we have the two types, the radial EBUS and the linear type, sometimes known as a convex probe EBUS. And obviously it's the latter, which we're going to be featuring mainly today. But the radial EBUS, just for completeness, and some of you may not have seen this before or been aware of it, this is these are photographs of the radial EBUS probe, which essentially on the left-hand side image is a catheter with a small balloon on the distal tip. And through that catheter, you insert the EBUS probe, which as you can see in the middle panel there. So in the middle panel on the right-hand device is the actual EBUS probe, which goes down the middle of the catheter, and then the water-filled balloon can be inflated. So on the right-hand panel, that's what you get at the end of the day. So you put the scope in, you then put the catheter and the probe down out the end of the scope, inflate the water-filled balloon, and the little ultrasound probe, which you can see in the middle of the water-filled balloon there, then spins through 360 degrees. Is actually attached by a wire to a little motor, and that spins the probe through 360 degrees. And what you get is an image like this. So if you look at the left-hand panel, this is the probe, which you can see there sitting in the bronchus intermedius, which is the BI. And you can see this 360-degree radar type appearance, as it were, and the ultrasound image. And then down at 5 o'clock, you can see this lymph node there. So this allowed you to go down to where you believe the lymph nodes were and actually see them. But of course, you couldn't then do a biopsy in real time. What you then had to do is take that EBUS apparatus out of the scope and then put the Wang needle, the TBNA needle down, and again through the airway wall into the area where your radial EBUS had helped you identify the lesion. There are other approaches for radial EBUS. On the right-hand panel, this is a high-resolution image showing the various wall layers. Now, some people have used it for actually looking at tumor invasion through the wall layers to try and determine whether you've actually gone through the cartilage ring or not, and to help with resections and that sort of thing. But again, these very few groups of people, I think, use this application. The other application, which I've not shown here, is radial peripheral EBUS, where you're doing localization along with for sort of nodule localization for peripheral biopsies, but that's beyond the scope of today. But I just include this bit of information about radial EBUS that was used by some groups quite extensively up until the sort of advent of linear EBUS. But I think it's fair to say that the majority of people have now moved on to linear EBUS. That's really been the game changer. And here we have the setup. As you'll see later on, there are different Olympus EBUS linear sets available now. There's the 260 scope, there's the thinner, newer 290 scope, and various ultrasound platforms linked to that. And the role really of linear EBUS is diagnosis, and in particular, as we'll show you later, the staging of lung cancer. Also for biopsy of parabronchial lung masses, and also biopsy of indeterminate mediastinal lymphadenopathy, which may be due to extrapulmonary malignancy or sarcoidal TB. And in fact, Ricky later on will give a talk about the use of EBUS TBNA for non-malignant disease. And then finally, as I'll show in a moment, it has an important role these days in molecular diagnostics. So how does the EBUS scope work? This is a very nice schematic showing the setup. So you've got the scope obviously at the bottom in that line diagram with the small water-filled balloon, which you can inflate around it. That's shown in gray there. And that obviously helps provide a good contact with the airway wall, because as you know, ultrasound can't pass through air, it can only pass through liquids or solids. So you've got to maintain good contact with the airway wall. Unlike a normal end-on viewing bronchoscope, where the optics are at the end of the scope, so you see exactly where you're going, the optics on this EBUS scope are set back behind the ultrasound probe, and the needle comes out at that angle, as you can see, at about 20 degrees, and passes through the ultrasound plane, shown by that little fan. In that yellow circle is the area where you normally biopsy. So you have this forward oblique optics view, and the needle comes out in the plane of the ultrasound. So moving on to the lymph node stations, as I said, Neal will expand on this in his talk, but essentially this is a historical figure, but I think one of the clearest ones available actually, and it shows the various mediastinal and hilar lymph node stations that you can access by EBUS. If you're new to this, it's quite useful to sit down with well, in the old days, a textbook of anatomy. On the new, nowadays, I'm sure lots of online models that you can look at and sort of learn and revise your anatomy of the mediastinum. Because to do EBUS well, you need to have a good three-dimensional knowledge of the mediastinum in your head when you're doing the procedures, and be able to understand the relationship of structures to each other, so that you can then in your head process the CT and maybe the PET images you've got in front of you with the endobronchial view as you're doing the procedure, the ultrasound view of the targets you're looking at, and understand how these structures relate to each other. So the lymph nodes in the mediastinum are numbered 1 through to 14, 1 being higher up in the neck, not shown in this figure, but then single digit numbers, so through 2 through to 9, are actually in the mediastinum, and then 10, 11, 12, 13, 14 are actually out in the lung itself, and out towards the lung parenchyma, and the higher the number, the more distal. So normally with EBUS, we look at stations 2, 4, 7, and then 10 and 11 are the main ones. And then the figure on the right shows the 2 lymph node stations, stations 5 and 6, which lie lateral to either the pulmonary trunk or the aorta, the arch of the aorta, which it is very difficult to get at. You can sometimes see them through, windowed through the pulmonary artery or the aorta, but you can't actually usually biopsy them. But more of that later. And there are different approaches to the lymph nodes. Historically, the surgical approaches are mediastinoscopy, shown in the left-hand panel in the red circle, or a video-assisted thoracoscopic procedure, either to get at those station 5, 6 lymph nodes, or possibly to get at the lower station 8 and 9 lymph nodes. But if you, and on the right-hand side, it shows in red, in the panel on the right, the areas you can get at by EBUS. So stations 2, 4, 7, 10, and 11 generally. And by endoscopic ultrasound, EUS, you can look at the left paratracheal lymph nodes, stations 2L and 4L, and also the subcarinal lymph node station 7, and get down to 8 and 9. And if you put the two together, as we'll show you later on in the morning, you can get at the majority of the mediastinal and hilar lymph node stations, as I say, with the exceptions of station 5 and 6. So how do we do EBUS? And we'll show you this, more of this on the recorded cases. And also it depends on your local approach. But there are different approaches to anesthetics. Some places use very deep sedation, using either patients who've been intubated or with a laryngeal mask, sometimes with anesthetic assistance. And propofol is widely used in these setups. And I think this is the setup that Neal is very lucky to have, Neal and Ricky have at UCL, where they have anesthetic support during their lists. So they have very well sedated patients. We in Cambridge and many other places, I think more commonly, use local anesthetic and moderate sedation. We give lignocaine to the throat and the cords using a spray. We also in Cambridge use a cricothyroid injection of about 3 mils of 1% lignocaine through the cricothyroid membrane. That actually works extremely well and gives really good anesthetic to the trachea and also to the vocal cords. And then we use midazolam and fentanyl. Some places use alfentanil. We use fentanyl in small doses. There you can see midazolam between 1 and 5 milligrams, or fentanyl 25 to 100 micrograms. And we use that in a stepwise approach. So we might start with 1 milligram of midazolam and 25 fentanyl. And then we just give incremental small doses of each drug as required, titrating the dose to the individual patient's requirements. As you'll see in the recorded cases, how you set up the room is important. As with any procedure one does, getting doing your homework and setting out everything you need in advance, I believe plays a huge role in the success or otherwise of your procedure. And this is our setup. So we stand behind the patient when we're doing these procedures. So we have the patient lying supine on a bed. We stand behind the patient. We have the screens in front of us, so you can see the screens there showing the CT and PET imaging, and also the ultrasound. So we have those right up in front of us. We have the stack on the right-hand side, shown by the green arrow, and the control panel there. So that is the EUME2 ultrasound platform, shown by the green arrow, with the control board just beside me. So I think, actually it's one of my registrars, Nicky Veal there doing that procedure, but he's got the keyboard just to his right side, so he can change the images if he wishes. We're supported in the room by an assistant EBUS practitioner. That might be another consultant, it might be a registrar, it might be one of our senior trained nurses who can do TBNA. And then we usually have 2 other nurses in the room with us. One to support the operators, who's usually standing just in front by where the green arrow is, actually at our shoulder. And the other nurse is at the other end of the patient, more or less where the red star is. And they are keeping an eye on the patient. The yellow arrow actually shows a tray containing the midazolam and fentanyl, which we connect to the patient with a long line, and we can give drugs as we go through the procedure. And we also monitor pulse, blood pressure, oxygen saturations, respiratory rate, as you can see there on the monitor. So the patient is very well monitored, plenty of support for the patient and the operator. And as I said, the room setup we've worked on over the years and just got it as we like it in an ideal way. So it makes everything very easy. And then when we actually do the procedures, as we'll show you in the cases, we image in a systematic fashion. So as I mentioned earlier, you need to revise your anatomy and learn where the lymph node stations lie. So when you, for instance, next time you do a bronchoscopy, when you go down, you need to be able to say, right, if I am at this point in the airway, you know, just at the junction of the, you've gone down the bronchus intermedius and just at the, below the right upper lobe takeoff, if I look through the airway wall at this point, what will I see? What will I expect to see? And I expect to see that the 11R lymph nodes and associated vasculature, for instance. So we, depending which side the tumor's on, so let's imagine for the purposes of this, the tumor is on the left-hand side. We would then start and on the right-hand side with our endoscopic evaluation. We'd start in the right hilar area, look at stations 11R and 10R, and then come back up the into the look at the subcarinal region, and then come up the right tracheal wall, looking for the azygos vein, and then stations 4R and up to 2R, and then we'd go back down to the left-hand side, to left hilar region, look at 10L and 11L, and then come up to station 4L between the aorta and the pulmonary artery, and then up above the arch of the aorta to station 2L. And we'll show you all that in a lot of detail on the pre-recorded cases. So again, with the TBNA, when you're doing the needling of a lymph node, our advice, if you haven't done this before, and I'm sure those of you on the call who have done this probably went through this route, our advice is to practice on models. First of all, you need to know exactly how to set the sheath so that when you do the TBNA, you don't damage your scope. The scopes are very expensive. Repairs to scopes are expensive, and it obviously takes your scope out of action while it's being repaired. And it is very easy, if you don't know what you're doing or are careless, to actually damage a scope and puncture the working channel of the scope with the needle. As I said earlier, working with a colleague, one person driving the scope, the other person doing the TBNA, we think is the ideal way of doing it. Some places they are sort of a one-man band and they do it everything themselves, but I think that is more challenging. It's okay if you've got big targets and the patient's behaving themselves on the table, but if the patient's wriggling around or coughing a lot and you're going after multiple small targets, it does become a lot more tricky if you're doing it by yourself. So as I said, you identify all the potential targets prior to starting the TBNA procedures, and you work out the order in which you're going to do the biopsy. So again, on this figure, the red star represents the primary tumor. So in this case, if we were sampling lymph nodes, we would start on the contralateral side, the right-hand side, which are the N3 lymph nodes. And then we would sample those first and then go to N2 lymph nodes, and then across to the ipsilateral side, the N1 lymph nodes, and then potentially the primary tumor if you can see it as well. And the reason we do that is that the needles are quite expensive and we don't want to use lots of needles in the procedure. We tend just to use one needle for most procedures actually, but you want to use the N3 lymph nodes are your highest station lymph nodes. So you want to sample those first, and then the N2 and then the N1, because if you started with the primary of the N1 and they're malignant, there is a theoretical risk of carryover of tumor cells on your needle to an N2 or an N3 lymph node if you biopsied them in the wrong way round. And theoretically, and it has been documented, theoretically you can inadvertently upstage a patient when you're doing the procedures, which obviously would considerably change the potential treatment for a patient who, it's a patient who doesn't have N3 disease. You cross-contaminate and the pathologist says this 10R lymph nodes actually got malignant cells in it, when in fact it doesn't, and you've got a false positive. So that's why we do the needle puncture in that order. We can use color flow Doppler to look at structures. Here we can see a lymph node at the top with a needle in situ, and Doppler on a blood vessel. And it's very helpful for helping differentiate mass lesions from blood vessels. Finally, just mentioning using the EBUS scope in the esophagus. This is something we do a lot in Cambridge, and some other groups are doing this as well, quite a lot. We quite often do an EBUS and then move on to doing endoscopic ultrasound, and we can look at, as I said earlier, various lymph node stations on the left side of the trachea, or lower down the esophagus as station 8 and station 9 around the inferior pulmonary ligament. And you can also have go down into the stomach, and you can look at the left adrenal gland. And we quite often biopsy the left adrenal gland if it's FDG avid, and there's concern about metastatic disease there. And we also sometimes can see liver metastases, and we've also biopsied liver metastases on a few occasions. And also celiac axis lymph nodes is another place where you often see metastatic cancer. So you can increase the reach of your procedure by doing EBUS in the esophagus, also known as EUS-B. So I think I've covered a number of things there, what we were doing before EBUS, the different types of endobronchial ultrasound, the radial and linear probes, a little bit about the basics of how the scope works, and then to be expanded on a bit about lymph node stations, and finally how we do EBUS, and touched on EUS-B. So thank you very much indeed.
Thank you very much, Robert. That was fantastic, a great overview to kick us off. And as you mentioned, I'm just going to, over the next 20-25 minutes, talk in a little bit more detail about the anatomy knowledge required to carry out EBUS. And as you said, Robert, there's no getting around this, I'm afraid. We have to have a very good and clear picture in our minds about the mediastinal anatomy. And what I'm going to do here is not go into a great deal of detail about all of the different structures in the mediastinum and the course of the vagus nerve, etc. But what I'm going to do is give you a very practical outline of what we need to know as EBUS bronchoscopists. So we're going to overview the mediastinal anatomy. We're going to particularly focus on the lymph node stations that that we commonly sample. We're not going to go through the exhaustive anatomy. What I want to also finish on for this talk is just putting it into context and why knowing the anatomy is so important. So a few years ago now, we've started using the TNM8 classification. This is recommended to us by the IASLC and the International Staging Project. And they've provided some very detailed maps and guidance for us to look at lymph nodes. This is the lymph node map, and no apologies for showing you this. You'll see, you've already seen a version of this from Robert earlier, and we will keep showing you this all morning. It's really crucial for when we're carrying out our EBUS procedures. So the TNM8 classification for lung cancer divides lymph nodes within the thorax into various zones. So station 1 we don't really refer to with EBUS. Obviously that's the supraclavicular zone that's usually accessible to ultrasound guided percutaneous sampling. I know some of my respiratory colleagues around the country do that themselves, but usually that's the remit of our radiology colleagues. So then we have the superior mediastinal zones, and this is really starting to be our EBUS territory. So as Robert has already mentioned, we've got the upper paratracheal, station 2 lymph nodes, station 3, which we divide into 3A prevascular, 3B retrotracheal, and I'll show you a bit more detail about all of these lymph node stations in a second. 4R and 4L, the lower paratracheal lymph nodes as well, commonly sampled. These are considered part of the upper zone of the mediastinum, so superior mediastinal lymph nodes. Then we also have station 5 and station 6. Station 6 being lateral to the aorta, 5 being lateral to the pulmonary trunk. And as Robert has already mentioned, these are usually not accessible to us via standard endobronchial ultrasound. Then if we move down to the station 7, a really crucial lymph node station that should nearly always be sampled when we're carrying out endobronchial ultrasound procedures. That's part of the subcarinal zone. Remember, there can be several different lymph nodes in each zone. So when we're doing the procedure, we may see several different lymph nodes, but we would still consider that station 7 or the subcarinal zone. And then the lower zone, station 8 and station 9, not accessible to conventional EBUS via the airway, but is accessible via the esophagus. Then any lymph nodes with double digits are not mediastinal, but they're hilar. So station 10 and above are N1 or hilar lymph nodes. So station 10 and station 11 routinely sampled, and then the more peripheral zone lymph nodes 12, 13, and 14. So again, here we have the lymph node map, and we've drawn circles around the areas that are routinely accessible to a standard endobronchial ultrasound procedure. So stations 2, right and left, 4 right and left, station 7, and the hilar lymph node stations. So there's been a whole wealth of literature out there now on sampling these lymph node stations, and particularly the frequency at which we do this. Now, this is fairly old data, but I think fairly representative, hopefully still, of the distribution of sampling that we tend to do when we carry out an EBUS procedure. So certainly in our practice, it's less common to sample the station 2 lymph nodes, but very common to sample the lower paratracheal and subcarinal lymph nodes, and also the hilar lymph nodes. And actually, to be fair, as practice has evolved and we now more routinely carry out staging procedures, we, I think, hopefully have improved considerably in terms of the systematic way in which we approach lymph nodes, which has increasingly been shown to be important. So let's now move and talk about the key lymph node stations in a bit of detail, and let's sort of dive into the anatomy a little bit more. So the first really key point to take away here is where the midline of the mediastinum is. And you can just see it here on the CT image here. It's the left lateral wall of the trachea. So the midline of the mediastinum is considered as the left lateral wall of the trachea. So everything to the left of that is considered on the left, everything to the right is considered to the right. So our radiology colleagues who refers to a pretracheal lymph node is in fact referring to a right-sided lymph node. So let's start with station 2L. You've got a nice view of it here on the CT. Remember, it has to be left to the left lateral wall. And then in terms of the craniocaudal location, it's defined as being above the aortic arch, that would be commonly sampled for a patient with a left upper lobe tumor, for example. So that's station 2L. Let's look at 2R. So you can see here on the CT image in the center that this lymph node is anterior to the trachea. But as we've said, the midline is the left lateral wall. So this is a right-sided mediastinal lymph node. So this is a station 2R lymph node. According to the TNM classification, the technical definition of it is the inferior border of the intersection between the brachiocephalic vein with the trachea. Now, that can be quite difficult to visualize sometimes via endobronchial ultrasound, but in practice, it essentially means the apex of the aortic arch. So what I tend to do in practice is we look on the left-hand side of the trachea, we pull up until we see the apex of the aortic arch, which is usually fairly easy to identify. And above that, we know is the station 2 lymph nodes on the left and on the right as well. So if we were bronchoscoping from behind, we've got the tracheal rings anteriorly towards the top there, and we can see these would be typical positions that we would want to look for station 2L and station 2R. The key point being that they're above the aortic arch. So let's move on to station 3. So not a very common site to be sampling, just we don't tend to see it very commonly in our patients with lung cancer. But when we do see it, when we do have a station 3P lymph node, it's pretty straightforward, I think, for us to sample simply just posterior to the trachea. The station 3A is anterior to the SVC and not conventionally accessible to EBUS. So the station 3P extends from the sternal notch all the way down to the carina, so simply posterior to the trachea. Right, let's move on to station 4L. So you won't forget that the midline of the mediastinum is the left lateral wall. So the station 4L lymph node is often quite a way over on the left side of the mediastinum. Everything to the right of that line is station 4R. It's clearly outlined by the schematic here. And just to remind you about station 3B posteriorly here. So station 4L to the left side of the lateral wall of the trachea. In terms of the craniocaudal margins, as we've said, it extends from the upper margin of the aortic arch. Remember, above the aortic arch is station 2, so below the aortic arch becomes station 4, and it extends down to the upper rim of the left main pulmonary artery. So on the left, we've got the two main structures that define station 2, 4, and the hilar structures, which is the aortic arch and the upper border of the left main pulmonary artery. A really key thing to take away from this particular talk. On the right, we've obviously got the same upper border at the level of the aortic arch as we've discussed, and then the inferior border is the inferior border of the azygos vein. And if you're not familiar with the azygos vein, I would strongly recommend you befriend it. And when you're next doing a procedure, specifically spend a minute looking at it, finding it and following it as it drains into the SVC. It's a really helpful structure, and as you can see here, really crucial because it defines the difference between a station 4R mediastinal lymph node from a station 10R hilar lymph node. So a really crucial and important structure. So just to recap, the station 4R is everything to the right of the left lateral wall of the trachea. It starts at the upper border of the level of the aortic arch, and the inferior border is the inferior border of the azygous vein. So what does that look like in practice? The 4L lymph node tends to be quite lateral, as we've seen on the CT imaging. The 4R lymph node can be quite lateral, but is often more anterior. But obviously, we're going to be guided by the ultrasound imaging and CT imaging and PET imaging that you'll have prior to the procedure. Just to reinforce this issue about the azygous vein, it's a really crucial structure for us on the right-hand side of the mediastinum when we're carrying out an EBUS procedure. As we've said, the lower border differentiates 4R and 10R. It's always described as being slightly kidney-shaped, and you can find it at the usually at the angle between the trachea and the right main bronchus on the right. So when you're next doing a procedure, do go and look for the azygous vein. Station 7, as I said earlier, really important lymph node station, should always really be sampled when we're carrying out staging EBUS procedures. Usually fairly straightforward to define and identify. Just below the main carina, we can often see the pulmonary artery when we're scanning and sampling the station 7 lymph node. On the left, it extends right the way down to the left lower lobe bronchus, so quite a way, all the way down medially on the left main bronchus. So the lower border on the left is all the way down to the left lower lobe bronchus. On the right, similarly quite far down, so the inferior border of the intermediate bronchus on the right. So actually, I'm always quite surprised about how far down sometimes you have to go and when you sample still includes station 7. So a very important central lymph node station. Can obviously be approached either from the left main bronchus or the right main bronchus, and that's going to be determined obviously by the ultrasound appearances and perhaps can be thought about prior to the procedure with the benefit of cross-sectional imaging. So we've covered station 2, station 4, and station 7. We've really highlighted the difference between the borders of station 2 and station 4 in the hilar lymph nodes. So let's now move to discuss the hilar lymph nodes in a bit more detail. Essentially, they're adjacent to the main stem bronchi. As we've said, on the right, they're below the inferior border of the azygous vein. On the left, they're below the superior edge of the left pulmonary artery. So hilar lymph nodes, obviously really important. I think increasingly we're being asked to sample them given the increasing use of SABR for lung lesions. I think it's vital now that we become very comfortable with sampling hilar lymph nodes. So those are the main lymph nodes I wanted to cover that we really need to have an in-depth knowledge of. So stations 2, 4, 7, and 10. You're going to identify the azygous vein next time you do the procedure. It's obviously always really important to look at the cross-sectional imaging. A CT with contrast is really crucial to help us to understand what lymph nodes we're going to do. And obviously patients with lung cancer, ideally we want a PET CT prior to our staging procedure. As Robert mentioned, we have the Doppler function available to us. It should be used routinely. It can help just differentiate vascular structures that obviously we need to avoid. It can also help to identify small blood vessels within lymph nodes, and we can avoid those blood vessels within the lymph node when we're sampling. So don't forget the Doppler function. Just in a few minutes, I just want to emphasize this once again as to put sort of the importance of these lymph nodes into context for our clinical practice. We know the importance of staging. We do it all on our MDTs, but why do we do it and why is it so important? Well, it tells us about prognosis, first of all, to help us have discussions with our patients, and it also helps our MDT to come to a treatment decision, and also helps with clinical trial recruitment and allows comparisons between clinical trials. And it's worth just reminding ourselves about the huge difference in outcomes between stage 1, 2, and 3 disease. And you'll recall, although there are complexities to this, stage 1 is a lung lesion within the lung parenchyma, stage 2, often a hilar lymph node, and stage 3, a mediastinal lymph node. So these huge differences in 5-year survival, the 92% when there are no lymph nodes involved, down to 36% when often N2 lymph nodes are involved. And that's just emphasized here in the TNM8 classification. If we simply look at survival by nodal status, you can see the huge difference in 5-year survival simply by nodal status. So getting the N classification correct is really crucial for our patients. And that's why knowing the anatomy of what is an N1 node, what is an N2 node, and what is an N3 node is really crucial for patient management. I think Ricky will come on and discuss this a little bit more later, but what's been evident from the literature in the past is that actually our techniques from working out whether lymph nodes are involved from cancer in the past have been suboptimal. So if we simply use imaging, so CT, for example, just by size criteria, we're only going to pick up half of the lymph node metastases. So CT conventionally uses a 10 millimeter short axis cutoff to say that a lymph node is positive. If we use PET-CT, it's better, but still not significantly improved. And I hope there are no surgeons on the line who are looking at those figures for mediastinoscopy. Let's look at some of the guidelines when it comes to sampling these lymph nodes that we've just discussed. So the ACCP guidelines is currently being updated, but this, I think, will still remain a very important recommendation. So for patients with mediastinal lymph node enlargement and no distant metastases, invasive confirmation of the radiographic stage is recommended, regardless of whether a PET scan finding is positive or negative. So I hope we're all doing this in our clinical practice. If there's an enlarged lymph node in the mediastinum, and that's going to affect that person's treatment decision, that should be sampled, whether it's PET positive or PET negative. This is really to say that the same thing is repeated in the ESTS guidance, which also adds the fact that when the primary tumor is greater than 3 centimeters, we should also consider invasive mediastinal staging with EBUS. And the most recent NICE algorithm confirms that for us. All intrathoracic nodes greater than 10 millimeters should undergo an endobronchial ultrasound or sampling with EUS in order to clarify the nodal status, which, as we've said, is really crucial for determining the nodal stage and the patient management. No apologies for showing you this lymph node map again. We really want it to be burned into your retina so that when you are doing your endobronchial ultrasound procedure, you're able to visualize this very clearly. And as Robert says, when we're doing a staging systematic approach to EBUS, we have this N3 followed by N2 followed by N1 approach. I'm going to, in the interest of time, move on from this, because I think Ricky's going to talk a little bit more about the important impact that EBUS can have on lung cancer outcomes. So, in summary, mediastinal anatomy is complex, and I'm not going into the ins and outs of the detail of mediastinal anatomy, but what we've done is hopefully highlighted the crucial lymph nodes that we need to have a huge amount of detailed knowledge about, in particular where they are, how they can be approached endobronchially, and what the landmarks should be. A quick reminder there in that cartoon to utilize the Doppler function. I hope we've already emphasized how important accurate mediastinal staging is to non-small cell lung cancer management. I hope we've starting to ram home the message about systematic staging approaches. So at N3, N2, followed by N1, and that we shouldn't trust the PET-CT imaging if lymph node status is affecting the patient management, and we really should be sampling these lymph nodes to determine their status. Good. Please do send us your questions. That's the end of the introductory talk and the end of the anatomy, and now on to the main course, what you've really come to see, which is a live procedure. So I'll hand over to the video.
Thanks very much, Neil. We're going to show you a recorded case now that Alana Barker, who's my consultant radiology colleague, and I performed a few weeks ago. It runs for about 40 minutes. I've provided a commentary as I did the case all the way through, and we can certainly discuss various points afterwards. It is essentially pretty much unedited. So you will see, everything warts and all, as it were, as we go through. But I hope that the commentary does highlight many of the anatomy features that Neil has just so elegantly told you about, and the various landmarks. So I'm just going to set it running.
Good morning, I'm Robert Rintoul. I'm an academic chest physician. I'm a specialist in bronchoscopy and endobronchial ultrasound here at Royal Papworth Hospital.
And I'm Alana Barker. I'm a consultant radiologist, and I specialise in thoracic oncology, and I'm trained in EBUS in the US for staging of lung cancer, and I do a weekly list with Prof. Rintoul here.
So the first case we're going to show you is a 79-year-old lady. She's been referred to us from a district hospital. She presented with some cough, weight loss, went on to have a chest x-ray, which is abnormal, followed by a CT scan showing a mass in her right upper lobe. We're going to show you her imaging shortly. Other than hypertension, she doesn't have any other significant past medical history.
So this is case one. On the left here, we have the PET-CT and the reasonably contemporaneous staging CT with contrast. And we can see that she has this large right upper lobe mass, which is involving the second rib. There's some sclerosis there. And this has avid uptake with an SUV of 19. And then further down, we've got this large, size significant 11R node, which has an SUV of 14. And this is the one that we'll be looking for with EBUS. And then there is a very small 4R, which doesn't have significant uptake in the PET, or hasn't been reported as such, but we will definitely be having a look at during the EBUS. And I'm just going to show you the lung parenchyma. And we can see that she hasn't really got significant lung disease. And that's borne out in her reasonable FEV.
Okay, well, good morning, everybody. We're just going to start this first procedure. And I'm just going to intubate. So we always stand behind the patient with the patient supine. And we've got a mouth guard in place here, which you can just see on the endoscopic view. And I'm just going to put the scope in over the tongue, like so, and just gently go down. The patient's sedated with 2 milligrams of midazolam and 50 micrograms of fentanyl, and has had a cricothyroid injection performed already. There's the epiglottis there, and you can just see the vocal cords beyond, the false cords, and I'm just going down now onto the cords, and you can just see a little bit of blood on the cords from the cricothyroid. We're just going to put some local anesthetic on top here, some lignocaine, just dribbling it down gently. There's really no response from the patient, which is good. Cricothyroid is probably working nicely. This is the sort of view you get with the offset optics. Okay, that's fine. Going to let that local anesthetic take effect for a moment or two, and just give another milligram of midazolam. Okay, I'm just going to gently advance the scope here. It's like walking through a door, looking up at the ceiling. And there's the apex of the cords just underneath the tip of the scope. I'm just going to gently advance the scope through the cords and into the proximal trachea. Okay, lovely. We're just going to put some endotracheal lignocaine in place. Could I just have the table up a notch or two, please? Just bring the table up a little bit. That's lovely, thank you very much. So I'm just working my way down the trachea here, a little bit of blood from the cricothyroid injection. We'll just hoover that out. That's lovely. Here's the main carina. Go. Lovely, thank you. Good, so here you can see the tracheal ring is anteriorly and the trachealis muscles posteriorly, and left and right as you see them. Could I have another lignocaine in the right, please, there? And one more in the left, please, in there. Super, thank you. I'm just going to let all that lignocaine take effect for a moment or two before I advance any further. So we'll just give her a... In a moment, I'm going to start an endobronchial inspection. The views are somewhat limited with an EBUS scope as compared with a normal flexible bronchoscope, but we still get a reasonably good view. We've got high quality CT anyway, which doesn't show any obvious endobronchial abnormalities. I'm not expecting to find anything particularly exciting, but we will have a look anyway. So I'll just start, first of all, on the left main bronchus. Just advance down here. It's slightly distorted. Set. Let's get round the bend. I just have a flush, please.
thanks. Okay, then we have the left upper lobe and lingula at the top of the picture on the endoscopic view, and that all looks fine. And then the lower lobe, which I'm not getting a great view of at the moment there, at the bottom of the picture. There we go. If you go too far with the scope, if you push the scope in too far, you lose the imaging because of the position of the camera set back from the tip of the scope, and its offset viewing, you will lose the image. So you just have to look from a bit of a distance. It's not the same as using an end-on flexible bronchoscope. So then coming back on the right-hand side, going in, we have the right upper lobe here. You normally get a nice view into the right upper lobe due to the offset view. Here you can see the three divisions, apical, anterior, posterior, the right upper lobe. A little bit of erythema there on the airway, and then just running down into the bronchus intermedius. And there's the middle lobe. Let's get rid of those secretions. There's the middle lobe there, and the lower lobe with the apical lower on the down at sort of 5 o'clock. Let's turn, that's the apical lower there. Yeah, thank you. Super. Okay, so nothing too much to see there. So we're going to start a systematic examination of lymph nodes now. So could we go on to ultrasound as well, please? And we've got the ultrasound here with picture-in-picture, and here is the main carina. So I'm going to start on the left-hand side, and the first thing I'm going to do is just run the scope down into the, there's the upper lobe again, the lower lobe, lingula. I'm just going to run the scope down into the lower lobe here. Okay. You can see the apical lower on the left. I'm just going to look here on the left-hand side, and you can see there at the top of the picture a small lymph node. This is down in the 11L position. And a vessel behind it, or a branch of the pulmonary artery there. It's a small node, it's about 3 millimeters in short axis. It doesn't look particularly concerning in any shape or form. It's a flat, long node. So just coming back up now, slowly, from there, 11L, coming up, there's the pulmonary artery here. And you can see the PA, pleura behind it, lung behind it, down at the bottom of the picture. Coming up, I'm just looking anteriorly, laterally, just scanning, make sure there's no other lead. Then this brings us up now, there's the pulmonary arteries coming up into the 4L lymph node position here. In this area here. So we've got the pulmonary artery on the left-hand side of the picture, and the aorta on the right, just coming into view there. And then we just have up here at the top, this is the area where station 4L lymph nodes sit. And I'm just scanning around in that area to see what I can see. Just moving my top hand slowly backwards and forwards, like scanning around, looking in with a torch. There's a lymph node there. It's a sort of long, thin node running top to bottom. It's got a fatty center and some vessels running into it. Again, I'm not particularly concerned about that. You can see some calcium in the wall of the aorta there. That all looks fine. I'm not concerned by those nodes. I think they look normal. Sorry. Yeah. Then it's probably coming in here. Yep, you've just got the esophagus sticking its nose in here. There's the aorta, calcium in the posterior wall of the aorta. And if I come up higher, these are the great vessels coming off the top of the aorta here. And this is now up into the area of 2L in this area here. I'm just scanning around, having a look to see if I can see anything in this area. No. Okay, so we can just go back down again. Let me look at station 7. Subcarinal lymph node from the left. So I'll just go in here. This is again the esophagus there with debris in the esophagus. And just having a look around to see if I can see a subcarinal node. There's a node there, just above the I think that's esophagus. There with a node just beside it, small node just in there. Again, short axis about 4 or 5 millimeters. Sometimes you get different views if you look at the subcarinal space from either the left or the right. This is from the left. If I can now go over to the right-hand side and do the same thing, there's the main carina, and just dip down into the right main bronchus. And again, just look into this space. Here, there's a node there, and there are a pair of nodes there. They look a little bit darker. They're about 6 or 7 millimeters. I think we probably will be sampling those ones actually. They're probably not involved, but I think they should probably be looked at more closely. So that's the station 7 nodes there. You see the atria behind beating away. So I'm now going to have a look down the right-hand side, and here we are. This is the right side, right upper lobe there. I'm just going to put a tiny little bit, I haven't been using any balloon yet. I'm just going to put a tiny little bit of balloon up. You can just see it at the very bottom of my endoscopic view at 6 o'clock. And this is a node here, so I'm just below the right upper lobe there, going down into the 11L position, where we know, 11R position. We know they're on the CT, there's some nodes in this area, so I've just got to find them. Here is that large node that we see on this. There we go. There's the right upper lobe takeoff, and it's just below it here. You can see on the endoscopic view. And if I turn the scope anteriorly, so I'm pointing, you can see I'm pointing forward towards the patient's feet. You can just see this node coming in, large node measuring about 15, 20 millimeters there. And it's dark. It's homogeneous. Can't see a fatty center in it. Can't see any vessels. We might just put the Doppler on it here. 1 or 2 vessels around the edge of it, but not within it. So that is a very concerning looking node, which we will be sampling. So that's the 11L, and that's the key thing just below the right upper lobe takeoff. 11R takeoff, thank you, sorry. Okay, I'm just going down a little bit deeper into the right lower lobe just to check there are no other nodes in that area. But there aren't, so I'm going to come back up. And then yeah, please. So there's the right upper lobe here. and I'm just going to come above the right upper lobe. Now, the next thing above the right upper lobe, looking at, from the trachea on the right side, you can see it's find the azygos vein, and here's the azygos vein. And you can see the azygos vein here with some, the pleura behind it and the lung behind it there. And it looks like a cross section of a bowl. And if I follow it around the right side of the trachea here, you can see it tracking around the right side of the trachea. And then if I go anteriorly, it dips down into the SVC. Now, the point of finding the azygos vein, which is always a classical landmark, is that just below the azygos vein there is a tenar lymph node. So you've got the azygos vein, the tenar lymph node. Below that, on the left of the screen, you've got the superior pulmonary vein as well. So there's a node just tucked in there. And then below that, you've got the 11R node. So there's the azygos vein. And then above the azygos, we come up into the 4R lymph node territory. And this is an area I wanted to look at. There's the SVC, and there is a node there. It's quite fatty. It's got a nice fatty white center. I just show it to you there. Alana, can you just put on the cursor, maybe? Please. Sorry, I have to find that again. So there's the azygos. And then there's a tenar lymph node here. The superior pulmonary vein below it. Just superior pulmonary vein there on the left. And then below that, off to the left-hand side of the screen, would be the other lymph node we've just shown you. And then coming up above the azygos, as I said, there's a lymph node. A bit more balloon. So I'm now going to just hunt around in the 4R space here to see what else I can find. There are a couple of little lymph nodes just lying anterior to the SVC. On the PET, there was a little bit of activity in this area, but it was not much, and it wasn't actually reported on the PET report. So it may be, we may just have a look at that node with a biopsy if we can get a needle into it. Okay, so we're now thinking about the order we're going to do samples on. So we didn't see anything in 11L or 10L or anything significant in 4L or 2L, but there is a node in station 7 that we need to biopsy a couple of nodes, and then there's the node at 11R, and then maybe a node in 4R. So we have to think about the order we do this in. So we'll sample the mediastinal lymph nodes first, and then move to the 11R node. But first of all, we're going to show you how we measure up the sheath and for the needle. Okay. So we've already on here, if you just show my hands, we've changed the bung, and we're now putting down the needle, sliding it down slowly, putting in the top of the needle, and then clicking it across in position. And then if you look on the endoscopic view, you can just see the sheath coming out there, the green sheath. And we just put it so it always comes out at 2 o'clock, 1 o'clock, 2 o'clock, and we set it so we can just see it. Sometimes a little bit of a fiddle doing that. That's it, perfect. Having done that, I'm just going to wiggle my... Yeah, that's lovely. That's good. Okay. So we're going to take that out. So the first thing we're going to do now is go down and find our station 7 node, which what I saw from the right-hand side. So that's here. You can just see I've got a little bit of balloon up on the scope. I'm going to go down and find the station 7 lymph nodes that I had before. There they are, there's 2 of them, that's the pair I had before. These nodes didn't show up on the PET CT at all. There we go, just there. Okay, yep, lovely. So you can see these nodes probably measure about 8 millimeters in short axis. They're not terribly large. There's that one, and there's a small one just to the right of it, which is not quite so easy to appreciate. Okay, so Alana's just setting the... So we're going to bring the needle out onto the wall of the airway first until you just feel a little bit of resistance there. You can just see the needle there coming out top right-hand corner. And then we're just going to slide the needle down into the node there. Lovely. Remove the stylet completely. And then just, you can see a little bit of air we've introduced into the node. That's what the white marks are. And then we are just moving the needle backwards and forwards gently within over a few millimeters within this fairly small station 7 node. Good, let me just move it backwards and forwards. We never count, probably 20 or 30 times gently like that, it varies. Take the needle out, and then I'm just going to stay very still and just keep an eye on the node so I don't lose it. And Alana's now going to show the needle is now out, and you can see on the specimen pot there's the sheath as we advance the stylet through. That here comes the core of material, not very long, quite a short piece, but then this is quite a small lymph node. We then flush the needle with cytolite and then with saline to clean it. Do one more in that node. Yeah. We're going to take a second pass in this node. I don't think these nodes are involved. I think they're probably normal nodes. We can't be certain though, based on the ultrasound appearances alone. Okay, then my role is to get the node in an ideal position for Alana to then put the needle down. There's the needle coming down, and just pop it into the node like so. And then I stay absolutely still. You can see the way I'm standing. I've got my arm braced against my chest, so my right hand doesn't shake. Because maintaining these positions over time is, you do need to have reasonable upper arm strength, so you don't shake and move it too much. And then you can see the needle moving backwards and forwards inside the node. It's slightly harder to appreciate now because we've got some air in amongst it all, the little white dots. Great. Okay, take that suction syringe off, bring the needle back up. Okay, so we've done those nodes. Okay. So minimal bleeding, as you can see there. And now we're going to go and find the forearm node again. So I'm going to drop back onto the azygos, which is my landmark here. This is the azygos vein. And then just turning anteriorly, again, I know in this area, just here, there it is, were these two lymph nodes just anterior. There you are to the SVC. So we haven't got a lot of room to play with here. So we're going to have to be pretty precise on our biopsying. You've got two nodes. They're probably about 4 or 5 millimeters coming down. Okay. Okay, so Alana's got things ready, and I've got to just hold this node. Alana, we'll go for the one on the right, okay? Just hold this node in position. Here comes the needle coming down. There's the needle just coming into the edge of the node. That's it, sighted in the node, beautiful. We don't want to go too far into the SVC, avoid dodgy SVC. These are the nodes which I think should probably show the flicker of activity on the PET. Whether they're involved or not is another matter. There was another lymph node which had a very fatty center, which I'm not so interested in, but these ones are slightly darker. He's through. So, yeah, that's it. So Alana and I just talking to each other quietly. We always mumble away in the background to each other, making sure we get, I've got to position the node in an ideal position for her to get the needle in. When you're doing very small nodes like this in awkward positions, I think this is a two-man or a man and woman job rather than having one operator. Some places advocate one operator to do everything, but it's, in my experience, for small nodes in awkward positions, it is quite tricky to do everything. Okay, we've got no blood in the syringe, so we're not aspirating anything out of the SVC, which we don't want. Even if we did, we just pull the needle out because it's a very, it's a 21 or 22 gauge needle. I think this is a 20, is this a 21 or 22 gauge? 22 gauge needle. That's a lovely sample. And we'll do the other node in a minute next door to it. there's a nice worm of material coming out from that node. Alana, can I just have Doppler, please? Can you just give me some Doppler, please? So Alana, I've done the one on the right. Yeah, there's that one. And then I was just looking at this thing on the left there. Is that another one? Yeah, there are 3 nodes there, actually. There's a third one. So we've done the one on the right. We've got what's one on the middle. They're all being compressed. They look like they're pulsating like blood vessels, but they're not. They are nodes. And the reason is they're just being compressed by the tissues around them, the vessels around them. So there's, and you can see we're just going to go for the one on the left, I think, the slightly larger one. Bringing the needle down and just working into it. There we are. This one's about 8 millimeters, I'd have said, short axis. Okay, it's a sub-centimeter node. Okay, we've parked the needle in the middle of it. You can just see the bright tip of the needle. We're just fixing the syringe, and then we just move the needle. And when you do that, you can't see it because I can't show it to you, but when you push the needle into the node, it pushes the transducer away from the wall of the airway, so that you have to push with your bottom hand. The bronchoscopist has to hold the needle in position with their bottom hand. Very nice, very good. Okay, great. So we're going to put these samples in the same pot. Obviously, we use separate sample pots for each nodal station, and I'm just staying in position on these nodes, not moving. They're just above the azygos vein. There's the azygos. And they're just at the intersection between the azygos and the SVC. Do that one again. We normally take at least a couple of samples from each node. We've got a trio of nodes here. We've selected a couple of them, and we're there. That's the biggest one. Okay. And we're just gonna, but this is the one that's also got some fatty material in it. Okay, lovely. Okay, you can see the needle moving there nicely across the node, getting a good sample from that. I'm just fanning backwards and forwards slightly with my hand to try and get a different angle, so as the needle goes through, we try and sample slightly different areas of the node. minimal bleeding, as you can see, endobronchially. You can just see there where I've been, there's the main carina. Just above the main carina on the right-hand side, that's the position of a 4R lymph node. You always want to make sure you correlate the imaging you've got with the endoscopic view. So that's the azygos, that's the skinny 10R node. So I think we're going to go down now and biopsy the primary. We've got good samples there from those 4R nodes. Yeah, we're going to go down to 11R now. So new pop, please, for 11R. So I'm going to go down and find this node again, just clean the blood out. There's the right upper lobe. I've memorized the position I was in. It was just and then turned anteriorly, and there you can see this large node here, which is the very FDG avid node on the imaging, which we showed you earlier. And we're going to make sure we get plenty of samples from this node, because we were going to be not only requiring H&Es and immunohistochemistry, but we'll also be doing a molecular characterization on this node as well. So we want to make sure we get plenty of material for moleculars as well. This node is sandwiched between two blood vessels, so we're just come down over the top of the blood vessel there on the right and down into the middle of the mass, or lymph node, I should say. Okay. Hold on. No, I'll get it back. Yeah, come on. Okay, we just came out there because the patient started coughing a bit. We'll just reposition. No, you're okay. You're okay. Yeah, there you go. That's it. There. Okay. Go. Okay, drop down in there. There we go. Fine. Lovely. Okay, so we can see the mass, or the lymph node mass there. You're going to need on moving nicely within it. So this is at least 20 millimeters in size. Lovely. Okay, we're just going to take that sample and good sample. We're just pushing a little bit more lignocaine down onto the airway there, which is a little, not uncommon when you're biopsying a lesion like this. She is coughing a little bit. Again, it's just a position of moving the needle, moving my scope to give Alana the optimal view to get the needle in. There we go, in again. avoiding the blood vessel on the left, just beside to the left of the tip of the needle there, and avoiding the blood vessel on the right. Then we've brought the needle in over the top of that. So we've got this big node wedged between two branches of the pulmonary vein or artery, I think. There we go. We're getting good travel across this node, so over at least a centimetre or so. No blood in the syringe, great. And we'll do, this is the second sample, and we'll probably take one more sample, and then we're going to finish the procedure. Good sample, yeah, lovely. On the endoscopy.
Okay, we're going to just stop the video there. I hope you can all hear me okay again. We're just about at the end of the procedure there, sampling that 11R node, and we did it a couple more times. I'll just briefly tell you the outcome from the results, the pathology. The 11R node there at the end was shown to be a non-small cell lung carcinoma favouring adenocarcinoma. There were no mutations on the full molecular panel testing. The PD-L1 count was less than 1%. The station 7 and 4 R lymph nodes were all good samples, but were all negative for malignancy. This lady, as you know, had a large mass in her right upper lobe involving the chest wall and an N1 lymph node, but the N2 nodes were clear. So she was seen and met surgeons. Surgical resection would be possible, but it was decided in discussion with her that actually she would prefer to have chemoradiotherapy, given the extent of the resection and chest wall resection that was going to be involved. It would have involved taking about 3 ribs with the chest wall, and she decided that was going to be too much. So she went to have chemoradiotherapy, and we did that case fairly recently, so she's currently in the midst of that. So I hope you enjoyed that case, and I hope it's raised a few questions for you. And I'm going to hand back to Neal now to chair the Q&A session. Thank you very much.
Robert, thank you. That was fantastic. And I particularly enjoyed the highlighting of the azygous vein. I thought that was really beautiful at the beginning. And I also thought the samples, the video of the samples coming out of the needle into the solution also was very elegant. So thank you very much for that. That was excellent. Right, we've got some really great questions actually, and I'm glad we've got a little bit of extra time, I think, for discussion. So I think we'll just crack on with some of these questions. So the first one I think is a really good one. So from a governance perspective, as a chest physician, what training is required to be able to demonstrate competence to perform EUSB? And I wonder whether that's part of a broader question about competence in EBUS and bronchoscopy generally. But maybe I'll come to both of you, Robert and Ricky. Robert, why don't we start with you? What's your take on this?
Yeah, well, it's a really good question, actually. And so my background was, although I trained as a chest physician in Edinburgh, I started doing some endoscopic ultrasound there prior to the advent of EBUS. So this goes back to about 2002, actually 2003, and then started doing EBUS. So I was quite happy doing endoscopy, upper GI endoscopy. However, I've been asked this question a number of times over the years since, if you want to do EUSB nowadays, what do you need to do? Now, we all, as bronchoscopists, sometimes find ourselves straying into the esophagus at intubation inadvertently. There are actually, for chest physicians, no specific rules or regulations around this. Bronchoscopy is not regulated in the same way as endoscopy is by JAG regulations. So the answer to the question really is it's probably a discussion to be had with your local clinical governance team and your trust to explain what you want to do, and probably then to have discussions with your local upper GI endoscopists who will, and colleagues I know who have started doing EUSB have quite often gone and spent some time with upper GI endoscopists to learn a bit about upper GI endoscopy and also to learn about the risks. There is a small risk of esophageal perforation when you intubate the esophagus. You need to know what you're doing. So as I said, there are no strict metrics around this for chest physicians, but I think speak to clinical governance teams, use common sense, and make sure you and your own mind are happy with your competencies before you do it.
Thanks, Robert. Ricky, what are your thoughts on this? And what about the slightly broader issue of competence for EBUS?
Yeah, thanks, Neil. So really interesting question, because in fact, when I first read that question, I almost didn't read EUSB and I just read EBUS because it's a real problem. I sort of agree with everything Robert said. I think from an EUSB perspective, I think speaking to your upper GI colleagues is the way, and the way we've done it at UCLH is we have parallel lists running with our upper GI colleagues, and very frequently we can ask them to just come in and train us on EUSB, and that's how we've done it at UCLH. But definitely there will be some governance committee or a new procedure committee at your trust where you should start with before starting EUSB. So the interesting question about EBUS though is that there is really, as currently in the respiratory training curriculum in the UK, there is no EBUS, doesn't feature in there at all. It's performance in diagnostic bronchoscopy alone, and I think there is a huge issue in the UK when it comes to training in EBUS. Now, Europe are way ahead, so they have a training program with formal assessment in theory and training in EBUS and having to do assessments to prove competency, but we really don't have that here in the UK, and in fact even US. In the US, I don't think there is really a formal training program, but there are interventional pulmonology fellowships. I think this is something that we need to address, don't we, in the UK? Now, within Europe, they have something called a SAT score. So it's a competence of being able to show exactly what Robert's shown you today. So getting through the cords, intubating, looking after the sedation, identifying the lymph nodes, and performing a competent staging procedure. Now, I know that there is a BTS quality standard, isn't there, Neil, from 2014. Now, it's labelled as flexible bronchoscopy quality standard, but within there are a couple of lines snuck in on EBUS, which does say that you should be monitoring your EBUS, you should be monitoring your cases, you should be looking at your diagnostic sensitivity, which you should be maintaining as 88% and above. I would also say that you should be performing a minimum of 50 procedures a year to maintain overall competence. So I think there's an issue there in training, I think, Neil.
Thanks, Ricky. That's a really comprehensive answer. I agree. There is a slight gap there that I think we need to formally address as the use of EBUS spreads, and I think it's important to be able to show competence. Okay, what about the next question? Is there, Robert, this is probably to you, is there any evidence in favour of cricothyroid injection over other methods?
Yeah, thank you. So I saw that question come up, and I've been thinking about it actually. I couldn't off the top of my head give you references for the evidence based on that. It is something we've done locally for many years. When I joined Papworth, one of my interventional bronchoscopy colleagues was routinely doing them and trained me in how to do it. We've been all our registrars. In practice, we find it works very well. Usually the cricothyroid membrane is easy to identify just below the thyroid cartilage. And we clean the skin, and using a butterfly needle attached to a 5 ml syringe, explain to the patient what we're going to do, and pop in 3 mils of 1%. Patients always cough quite a lot. You want to warn them about that, but it helps spray the anesthetic around. What I can tell you is that often, if you invariably when you've sprayed the mouth and the back of the throat with some lignocaine, when you do then intubate and go over the back of the tongue, as I showed you on that case, you get a very good block around the cords, and we usually routinely put a lignocaine on the cords, as much just to monitor response. And if there's no coughing response from that, the cricothyroids work well, and you can just whip down straight through the cords and carry on. So it saves time, and we do it routinely. But I would have to go and look up evidence to prove that.
Yep, thanks, Robert. It was reviewed in the BTS bronchoscopy guidelines from, as Ricky says, many years ago, and there were randomised trials that didn't seem to show any difference. But why do you think, Robert, that it works well for you? Is that I've always thought it might be something to do with the time.
Yeah, I think it speeds up. It speeds up the procedure. So one of the things generally that I used to find when you intubate a patient and you sort of spray as you go, if you're hanging around in the back of the pharynx with the scope while the anesthetic's taking effect, patients often don't like that. They often cough and gag on it, as you know. So I think it, and you're sitting there for a couple of minutes putting all this local in, then waiting for it to take effect. So I think it does actually just speed up the start of the procedure.
So potentially it's the gap of the time between the installation of the lignocaine and the intubation.
Yes, I mean, by the time we tend to put the cricothyroid injection in, what we tend to do is we give the patient, once they've had everything, pulse and blood pressure, they've been sort of wired up, as it were, we give them a little bit of midazolam, initially a milligram or 2 of midazolam, and then we do the cricothyroid. And then we might give a little bit more midazolam or fentanyl and get everything ready to start the procedure. And that usually takes, 3 or 4 minutes while you're doing all that, by which time the cricothyroid lignocaine has taken effect.
Interesting, thank you. Okay, next question. Is recommended practice now that every patient with a primary tumour greater than 3 centimetres in size should undergo an EBUS to assess lymph node status? Ricky? Do you want to take that?
Yeah, I will. Yeah, very interesting question, isn't it? So, so in the European guidelines for the Society of Thoracic Surgeons, that is included as a rationale for doing EBUS. Now, what we're really talking about is PET negative, CT negative patients. So PET has a very, very high negative predictive value for detecting mediastinal disease in the lymph nodes. But there are a few sort of patient groups where actually that's not always the case. So, so taking this example here, so patients with primary tumours which are more than 3 centimetres, they can have, as some reported anything up to 20% occult disease in N2. So these would be N2 nodes, which on your PET and CT look normal, but actually when you go in with EBUS to take samples, they will be positive. There are other groups too. So those patients who have N1 lymph nodes, which are positive on PET. These patients should also have a staging EBUS. And again, these patients up to 20-30% reported occult rate of having N2 and N3 disease. And there's one other group, which is centrally located tumors. So this is all based on starting from a very old study, I think nearly almost 2 decades ago, on a TNM6 staging guideline, but patients who had central tumours were likely to have occult disease again in N2 and N3, and that's quite important for those individuals that are being sent for surgery. Now, I know that the NICE guidelines don't recommend staging for patients with primary tumours of more than 3 centimetres. I don't know whether Robert or yourself have any comments on that.
So you're right, it wasn't assessed as being a cost-effective thing to do. Having said that, the group of patients in whom I would certainly consider it is those undergoing SABR. So particularly large tumours for whom we're not going to obtain any other pathological lymph node status, I do think there is potentially a role for nodal staging. And just to add to the references, there was quite a big study in the ERJ published in the last year or two from David Ost's group at MD Anderson, that specifically look to define central tumours and look at the occult nodal positive rate. And I think probably had that been available at the time of the NICE guidance review, I think that would have probably changed the recommendation for invasive mediastinal staging. Good, Robert, did you want to add to that?
No, I agree. I think I entirely agree about your comments about SABR. I think this just reflects the fact that clinical practice is often, running a few years ahead of guidelines, which are always, to some extent, slightly reactive, but then obviously guide the future, as it were. So I think in future iterations of guidelines, looking at the most up-to-date evidence, you may see some changes there.
Thanks. Robert, what's your standard number of passes?
Right, so this question, the question is, what is the standard number of passes in a node and how many times do you sample each node? So 2 slightly different aspects. Mm-hmm. So a question we often get asked, very good question. And the answer is, it slightly depends what you're doing in that case. Now, if you just think about the case we just did, we had Station 4R and Station 7 nodes, which I thought were going to be, looking at them, likely not to be involved in malignancy, and indeed that turned out to be the case, but they needed to be sampled. And we had an 11R node, which clearly looked malignant and was going to be the money shot, as it were, and give us the answer. So when you go round, what I teach and train my registrars is that when you are doing your assessment of all your nodal stations, you obviously got to work out how many different stations are we going to biopsy. Now, you've got the patient lying there in front of you who's been already in the procedure 10 or 15 minutes as you've been doing your sort of tour. And then you've got to work out, well, how long is this procedure going to last and how many different stations have I got to biopsy? Now, sometimes we might have, 6 different lymph node stations to biopsy. And you're going to be doing multiple lymph nodes. So you then have to say, well, actually, if we do each lymph node 3 or 4 times, this is going to be a lot of biopsying, and it's going to take make a very long procedure. So in general terms, we will biopsy each lymph node twice. And if it is particularly suspicious, we will do it 3 or maybe 4 times, particularly like that 11R node that's clearly going to be malignant. And you want to make sure you get plenty of material for the pathologist who's going to be doing H&Es, immunohistochemistry, and then your moleculars as well. And certainly in recent years, we have increased the number of passes we are doing, or the number of times we sample a node, particularly the ones which we think are going to be critical, in order to make sure we get enough material for the pathologist. Because what you don't want to be doing is having to redo a procedure just to get more material for molecular testing. With regard to the number of passes in the node, and I think what the question it means by that is how many backwards and forwards do you do? I don't count them, but usually what we do is we try and fan through the node in different directions. And as I said to you, probably by the time you've gone backwards and forwards, you've done it 10 or 20 times. Every time I run a course, someone usually counts and tells me how many times I've gone through the node, and it's usually more times than I think. I know of 1 or 2 people who say, oh, we do 50 or 60 and we count them as we do them. I really don't think that's necessary. What is more important in a way is is to look at how much sample you've got coming out in your pot and see what you've got as well. That's an important aspect. Don't just hand it to the nurses and not look at. So you saw there, we were showing you each time what the sample looked like in the pot, and that wasn't actually just for the camera. When I'm standing there, I am looking across at the table and I'm looking at the sample and I'm saying, what's that sample like? That is another important aspect to it. So I hope I've answered your question. It's not a precise science. It comes with experience, but try and avoid redo procedures.
Thank you, Robert. Entirely agree with that. So to summarise, at least 10 to and fro's within a lymph node. And then during the systematic staging procedure, 2 passes into a node to determine whether it's benign or malignant, and then 1 node in which we want to get a full diagnosis. Robert does at least 4. I tend to do at least 6. There was actually a meta-analysis published in the journal Lung Cancer in the last few months that for the first time, I think, just showed the greater the number of passes, the greater the yield. So finally, some common sense in the EBUS literature. So I think some at least, for me anyway, at least 6 passes into a lymph node to get your full molecular panel and diagnostic material. And remember now, we're probably going to be moving in the next 6 months or so into the world of neoadjuvant therapies. So every patient with nodal disease, even if they don't have extrathoracic disease, will need to have a molecular status available for your MDT decision making.
Yeah. One other thing I'd add, Neal, to that is, of course, as we've touched on once or twice, you should be auditing your data as you go along, your results, and looking at your adequacy of samples for the immunohistochemistry and for the moleculars. And if you're finding you're not, your molecular pathologists are saying, actually, we haven't got enough material, samples aren't good enough, then you need to be reviewing what you're doing.
And that is a nice quality standard. So thank you for reminding us of that, Robert. Ricky, what size needle do you use and how do you select?
Well, I'll keep this one brief. So there are different size needles out there with the Olympus. There's 22, 21 gauge and 19 gauge needles. We would normally select a 22 gauge needle for our procedures. There are various studies comparing 22 gauge versus 19 gauge needles, and the jury is still out there as to whether one's better than the other. Recent studies in, for example, lymphoma haven't really shown a difference in diagnostic yield. I will say that the 19 gauge needle is quite flexible, and sometimes that's a concern that you may not be able to put your scope into a good position to be able to use that needle. But actually, the 19 gauge needle is very flexible, and you can do that. And I would say anecdotally, for non-malignant disease, say sarcoid and possibly lymphoma, it may be better. But you have to also remember, with a larger needle, there's more chance of getting blood into there and contaminating your sample with blood too. So I think the jury's out there, Neal, at the moment.
Thanks, Ricky. I'm quite a fan of the 19 gauge needle. I think it is definitely more flexible than the certainly the 21 gauge and probably the 22 gauge as well. But just in the last minute or two before we have a break, Robert, you've sort of mentioned this a few times actually during your case. But how do you differentiate benign from malignant lymph nodes just using the EBUS images?
So, in principle, smaller lymph nodes, less than 10 millimeters, are radiologically regarded as benign, but that's obviously not always the case. But the criteria, the things I'm looking at when I'm doing ultrasound is the shape of the node. So if it's sort of triangular or polygonal or oval, and if it's got a fatty center and if it's got central vessels, those are markers that it's more likely to be a benign node. Malignant nodes are usually larger, darker, more rounded up, have often lost their fatty centers or central vasculature. But it's not a precise science. If it was accurate, we wouldn't have to do all this biopsying. You can have very benign looking nodes harboring malignancy, and I've sampled many in the past and got surprises. And also, nodes that you think, oh, that looks a pretty suspicious looking node. I don't like the look of that. You've sampled it very thoroughly, and in fact, it's not malignant because it got some other process going on making it look a bit strange. So you can get a feel for what nodes are, but clearly, if you've got a lymph node, which is, sometimes you get nodes which are, very, very fatty, full of fat, and they are very unlikely to be malignant. But, these things, these sort of standard things you read in the text and papers are pointers, but at the end of the day, as we've been showing you, biopsy them.
Thank you, Robert. That's great. Maybe they can be used in an MDT session to improve the negative predictive value. So if you've taken a sample and it's negative, people are questioning it. Actually, maybe the ultrasound images, if they also suggest the node is benign, can just add to that negative predictive value, perhaps.
Absolutely. And I think, as I'll come on to this later on in my next talk, this question about if you have a lymph node that you've biopsied that is negative, should it have surgical, a mediastinoscopy to evaluate. And in our MDTs, if we have a node that, let's say a node is FCG positive, but we've biopsied it and it's non-malignant, the chair turns to me and says, what did you think of that node when you sampled it? If I say, I'm absolutely happy that it was a benign looking node, we've really, hit it hard several times, I believe the pathology. But if I have any doubt, I'm a bit surprised by that pathology result, I was a bit suspicious about that node, then we would go further.
Thank you very much. So that's been a really useful discussion, I think. Thank you very much for your questions. They were really excellent. Please do keep sending them in. What we'll do now is have a break and join back at 10:50, please.
Well, hello, everybody. Welcome back. Hope you're all back from your break and you've all had a cup of tea or coffee and something to eat. We're going to move on now with the second half of the seminar. And I'm going to give you a talk about the role of EBUS TBNA in lung cancer. And then Ricky Thakrar is going to give a similar talk, but he's going to be focusing on non-malignant disease. And then after that, we're going to have another of our recorded cases and another Q&A. So without further ado, moving forward. So again, my disclosures, which are the same as before. And then a poll. So in this poll, what we thought it'd be useful to know is that whether currently you only do non-ultrasound guided TBNA, or you do EBUS TBNA alone, or you can actually do EBUS and EUS at the same time, or you can do EBUS and EUS at separate times, maybe different teams, or none of the above? Okay, that's numbers are just jumping around a little bit, but we'll just give it a few seconds to settle down. Okay, that's interesting. So nobody is doing non-ultrasound guided TBNA anymore. Half of you are doing EBUS. And then actually, interestingly, about a quarter of you are doing EBUS in the US in the same episode, which actually I've noticed over the years is gradually going up. That certainly figure wouldn't have been as high 2 or 3 years ago. And then another 30% are saying they can do EBUS in the US in separate sittings. So it's around about 50% of you, for half of you, have access to EUS for mediastinal staging. Okay, great. So in this talk, I'm going to look at these objectives. We're going to look at the data on the evidence of efficacy for EBUS TBNA. I'm then going to talk about Neal's lung boost study. I'll then talk about the combined EBUS and EUS study, the ASTA study, which we performed over 10 years ago now. And then talking about mediastinal staging using the EBUS scope alone. So both EBUS and the EUS-B in one sitting and the evidence for that. And then finally a little bit about using EBUS for genotyping and molecular pathology and the guidelines. As we've said, linear EBUS for diagnosis and staging of lung cancer and parabronchial masses, extrapulmonary malignancy and molecular diagnostics. And as I said, Ricky will cover sarcoid and TB shortly. So what's the data? Now, the early on when EBUS, as I said, was first, people were starting off with EBUS. So in a sort of period 2005, 6, 7, 8, there were a number of observational case series being published by various groups, including ours. And then in 2009, GU and the European Journal of Cancer did a meta-analysis of 11 of those studies with about 1,300 patients, and showed that actually the pooled sensitivity for the detection of malignancy was about 93%, so actually pretty high, and the complication rates were pretty low. Now, retrospective studies always biased, selection bias and so on. People report in case series their good outcomes sometimes rather than all their outcomes, and complication rates vary depending how you classify them. But it gave an indication that actually EBUS seemed to, has potential as a pretty useful tool. And in subsequent meta-analyses or systematic reviews by Dong and then Gerard Silvestri, again with larger and larger numbers of patients, again we're seeing sensitivity for detection of malignancy, bordering out about 90%, something like that, give or take, with a negative predictive value of around about 90%, which actually for any diagnostic test is pretty impressive. You're never going to get, up to 100%, but any diagnostic test that, is running around about the 90% mark is generally regarded as pretty good. Then looking at slightly more complex studies, there were a couple of studies published, one by Yasufuka and another by where what they did quite elegantly in a way was to take patients who required mediastinal staging, to do an EBUS on them, sample all the lymph nodes, and that was sort of done in a theatre type setting or an anaesthetic type room type setting. And then the patient immediately proceeded to have a cervical mediastinoscopy performed to sample by that route. And then they compared the outcomes from the EBUS TBNA with the cervical mediastinoscopy. And as you can see, the sensitivities between the two were fairly similar, possibly slightly favouring EBUS. And I think the reason for that is that EBUS has that little bit extra reach of getting at hilar lymph nodes as well, which medius diagnostically couldn't do. But overall, showing that it looked like the two different approaches were similar in outcomes. And again, there was some work from various groups, including our own, looking at the biopsy of parenchymal lung masses. And 3 papers I've listed there, all looking, again, from fairly early on in the journey, as it were, the EBUS journey, all showing that the sensitivity for biopsying parenchymal lung masses is pretty good. One thing to be aware about that, if you're doing them, is obviously, apart from the potential risk of things like pneumothorax, which occasionally happens. In fact, I did one earlier this week and gave the patient a small pneumothorax, is that sometimes the tumor, if you've got a malignant lesion, it's often got a lot of inflammatory change around it in the lung, and bits of infection and things like that. And you've got to also, try and get into the middle of these lesions to try and, and sample different areas of them, because they're not always all malignant. As I say, it can be composed of various other stromal components. So sometimes you do get negative results, which surprises you. But that's not uncommon with parenchymal lesions. So again, multiple sampling of different areas is the secret there. So the Lung Boost study. So this was the excellent study that Neal Navani and colleagues and Sam Janes at UCL performed, looking at lung cancer diagnosis and staging. And this was published in Lancet Respiratory Medicine in 2015. And essentially, what they did in this study was they compared conventional approaches to diagnosis and staging with using EBUS as the first approach. So here in this algorithm, you can see at the top, they took eligible patients with intrathoracic disease on a staging CT and randomized them to either having conventional diagnosis procedures or to EBUS up front. And essentially, you can see the various investigations at the bottom on the left that the patients had in the conventional arm versus either the majority had EBUS TBNA in the right-hand arm. And the very interesting thing from this study was that they showed very clearly that the time to treatment decision was significantly quicker in patients who had EBUS as the first investigation. So showing that actually doing a diagnostic and staging procedure in one go cut down in number of investigations and the pathway time by around about 2 weeks. So significantly quicker. And although it wasn't specified initially, they did an exploratory survival analysis, which initially surprised quite a lot of us, that actually the patients in the EBUS arm had better survival outcomes. And you think, well, why is that compared with, standard diagnostics? But actually, then when you think about it, you think, well, actually, if you've been diagnosed much more quickly and treated more quickly, your tumors aren't quite so advanced, because there's this concept called millimeters matter, where as a tumor grows in size and moves through the stages, your survival starts to go down. And this is reflecting, we believe, that phenomena, that actually the faster you get on and diagnose and treat a patient, the better their outcomes. So really important paper, and it significantly influenced the NICE guidelines, that piece of work. A few years prior to that, we'd done another study. I did this with colleagues in the Netherlands and Belgium, where basically we undertook a randomized trial of cervical mediastinopscopy versus EBUS in the EUS, which we called endosonography. And in this schema, again, you can see patients with suspected or confirmed non-small cell requiring mediastinal staging were randomized to either having combined EBUS-EUS on the left-hand side or surgical staging on the right. If the EBUS-EUS showed positive findings, the patients had oncological treatment. If they were negative, they then had a confirmatory surgical mediastinoscopy performed. And if that was negative, they went on to have surgical resection. And that confirmatory mediastinoscopy was put into the algorithm in conjunction with the ethics committees, who felt that because EBUS-EUS at that time was a new technique and an exploratory technique, that patients shouldn't be disadvantaged by not having a mediastinoscopy. So that was the design of the study. The null hypothesis, of course, there was no difference between the two arms for the detection of mediastinal disease. And the primary endpoint was the sensitivity for detection of N2, N3 disease. And if you look at the sensitivity on the top line there, you can see with surgery, cervical mediastinoscopy, it was 79%. And with EBUS-EUS, plus or minus a confirmatory mediastinoscopy, it was 94%, and it was significantly better in the endosonography arm. And that was the first time in a randomized trial, an endosonography first approach had been demonstrated to be better than surgical staging. And importantly, there was no difference in the prevalence of disease between the two arms, which you'd hope, obviously, in a randomized study. If you then said, well, what about EBUS or EUS alone without the surgical staging? So we sort of did a ad hoc analysis there. We found actually that EBUS-EUS on its own diagnosed disease 85% of the time and was comparable with surgical staging. So if you didn't do that confirmatory mediastinoscopy for the negative cases. But if you think about it, the sensitivity for EBUS-EUS alone was 85%. EBUS-EUS plus surgery for the negatives was 94%. That's a 9% difference between the two approaches. That means you have to do 11 patients have to undergo mediastinoscopy after a negative EBUS to detect one patient with N2 disease. So although we sometimes do that, that is one of the debatable points. If you have a competent EBUS-EUS procedure and operators, do you really need to do those confirmatory mediastinoscopies? Maybe something for the Q&A session. We also did a cost-effectiveness analysis and showed that the endosonography strategy had slightly higher quality adjusted life years and was cheaper. And that was borne out in different healthcare settings in the UK, in the Netherlands, and in Belgium, which were the three centres that randomised the patients into that study. Now, moving on, what about mediastinal staging using an EBUS scope alone? So this is, EBUS and EUSB. So Huang Bo did this, and she looked at EBUS alone, as on the left-hand side there. EBUS alone had a sensitivity of 84%, but if you added EUSB, you could push it up to 91%. And then the other, on the right-hand side, another study published in Thorax in 2014 by Kang, where basically they started either with EBUS or with EUSB and then did the opposite and compared the different approaches. The long and short of all this data, which sometimes takes a little bit of thinking about, is that actually the most efficient and efficacious approach is to do EBUS first and then add EUSB if you think it's going to add something extra. So our approach locally is to, as I say, to start with EBUS routinely, and we do EUSB if we think we're going to get at areas we couldn't get at with EBUS, or we want to have a look at some nodes like the 4L and the 7 by a different route, or get down to station 8 or 9 nodes if we think it will add extra information. So we don't do EUSB routinely on every patient. We are selective about which ones we do it on. For extrathoracic malignancy, and now a number of studies have been done, again, and meta-analyses have been done, which again, not surprisingly, shows that actually EBUS TBNA is very useful for diagnosing metastatic disease in the chest, from renal cancers, bowel cancers, and so forth, and a number of other malignancies. And, you know, we routinely and often get patients referred to us by other cancer services who have scanned patients and found mediastinal disease, or mediastinal adenopathy, I should say, and, you know, want to know if there's mediastinal disease or not. We've touched on this already and talked a bit about it previously, but, you know, how good is EBUS TBNA for getting samples that are going to be used for molecular pathology, which is becoming increasingly important. And the UCLH team have done a lot of work on this, actually, and published several papers on this, including this one recently in Chest looking at PDL1. But essentially, the bottom line is that these samples can be used very readily for genotyping, for EGFR, for KRAS, for ALK. We routinely run ours through next generation sequencing platforms now. The panels are getting bigger and bigger that they're running, but the samples generally are, you know, appropriate, you know, between 90 and 100% of the times. But again, you need to keep auditing this to make sure your samples are adequate, and that you are providing the molecular pathologists with enough material. And that's, you know, remember that maybe only a tiny amount of what you sample will actually have malignant cells in. We often think when we do bronchoscopy and take a biopsy or do an EBUS, that is, you got a nice sample in the bottom of the pot, it's all full of tumor. Well, actually, it's a really informative exercise to go and spend a day or two with the pathologist, actually looking at those samples and see just how little of your lovely EBUS worm of material actually might contain malignant cells. And, you know, sometimes the pathologists are making a diagnosis based on a relatively small number of cells. All this data is fed into national and international guidelines, and certainly the Lung Boost study and the ASTER study featured prominently in the NICE lung cancer guidelines in 2019, and have informed the current algorithm, which Neal showed you earlier. And in fact, in a number of the other international guidelines, which I've listed there from around the world, all, you know, quote these references. And this you saw earlier is the same algorithm Neal showed you in his previous talk from the latest NICE guideline iteration. So this is patients being considered for radical treatment, PET CT up front, and then depending on the outcome of the PET CT, you'll proceed to EBUS as your first test. So in this presentation, I hope I've covered these areas, and I'm very happy to take questions afterwards. And I think Ricky is now going to talk about benign disease.
Thank you, Robert. Lovely. Sorry, I've just got control of the screen now. So thank you. Yes, absolutely right. I'm going to be talking about EBUS in non-malignant disease. So all too commonly, we will So for some reason, I'm just struggling to move slides. Sorry. So all too commonly, we will see patients like this, bilateral hilar mediastinal lymph nodes, and it screens sarcoid, doesn't it? And EBUS has been used now nearly for 2 decades in patients who have appearances like this. So here's a Neal going into a station 7 lymph node showing non-caseating granulomas, and these early trials all showed that EBUS performs really well. So sensitivities of 88 to 93%. And this is proven again with this meta-analysis. Again, this now is a decade old, but you can see the pooled yields of 80%. Importantly, no major EBUS complications. Now, interestingly, they also looked at rows versus rows, and I'll touch upon that a little bit later, but there wasn't really a difference in whether institutions had rows available to them. Now, we've got a poll here. So that picture I showed you with this bilateral with its bilateral hilar mediastinal lymph nodes, you suspect stage 1 or 2 sarcoid. What's your modality of choice? What's the first test you would put the patient forward into? So click your answers in, and let's see what your approach would be. We'll discuss that in a bit more detail. Lovely. I'm glad that was the answer, but there are a couple of nuances that I'm just going to touch upon. So I put this in for the last few years, but actually I really shouldn't put this anymore. So I've noticed that nobody's doing conventional TBNA. I'm really glad we shouldn't be doing conventional TBNA for sampling lymph nodes in the mediastinum. It should all be done with EBUS. This trial's a decade old, so it's from it's called the granuloma trial, and it essentially evaluated endosonography, so EBUS and EUS versus conventional bronchoscopy. So this was 300 patients which were randomized into having either EBUS or EUS, and 150 patients who had conventional bronchoscopies. This is endobronchial biopsy, lavage, and transbronchial lung biopsy. You can see on the left-hand side of the screen, in the patients that underwent standard bronchoscopy, 72 granulomas detected, and in those that had EBUS or EUS, had 114 granulomas detected. So you can already see that EBUS and endosonography is outperforming transbronchial lung biopsies and diagnostic bronchoscopy. So here we go. This is the diagnostic yield, which sits at around 80% when we're looking at this trial, and standard bronchoscopy, which sits down at sort of around 50%. But really importantly, in the patients who have stage 1 sarcoid, we're not bronchial disease or parenchymal disease. Standard bronchoscopy just doesn't cut it, and actually we should be performing EBUS in all these patients. Interestingly, this trial showed that the EUS seemed to perform a bit better, but actually the same group only a few years later compared EBUS and EUS and showed there wasn't really any difference. I think the really important take home is that there were complications associated with transbronchial lung biopsy, and I think we have to really take that into consideration when you're thinking about what to put your patient through. Now, this trial from Neal at UCLH was essentially evaluating whether combining an approach with EBUS and standard bronchoscopy will improve the diagnostic yield in stage 1 and 2 sarcoid. Now, here are the results. Now, stage 1 sarcoid, EBUS clearly outperforms standard bronchoscopy, and there's no doubt there. But certainly in stage 2 sarcoid, you can see that when you add standard bronchoscopy to EBUS, the combined approach will increase the diagnostic yield. Now, you have to think about that carefully as well. Now, in this trial, there were no major complications, but in other trials, we know that transbronchial lung biopsies can cause bleeding and they can cause pneumothorax, so that you have to take that into consideration when you're evaluating your patients. The other lesson that came from this trial, so these were 40 patients who had suspected stage 1 and 2 sarcoid. They all underwent EBUS and standard bronchoscopy. What you can see, and what's very interesting, so 25 of them had a diagnosis of sarcoid, but interestingly, 7 had tuberculosis, carcinoma in 1 patient, lymphoma in 2. So that's a third of the patients actually had an alternative diagnosis, and that is important to take into consideration. So the lessons from this trial were EBUS followed by bronchoscopy is feasible. It's safe, but I will caveat that with that there are other trials showing there is moderate risk with bleeding and pneumothorax, and you have to take that into consideration. Adding in standard bronchoscopy to EBUS does increase your diagnostic yield, but that's particularly in stage 2 sarcoid. And obtaining a pathological diagnosis is important, certainly in patients with isolated mediastinal lymph nodes, because they may have an alternative diagnosis. Now, in the poll, everyone selected. Sorry, this should be selecting both EBUS, TBNA, and combination of EBUS diagnostic bronchoscopy. So, for patients who have stage 1 sarcoid and stage 2 sarcoid, EBUS TBNA is your first port of call. Now, you can add a diagnostic bronchoscopy on top of that, in particular for stage 2 sarcoid, which may increase your diagnostic yield, but there are risks with that. We touched upon some of the questions previously about how many passes. This very much just shows exactly what Neal said, which is the more passes you do, your diagnostic yield increases. As you get to about 6 passes, that sort of plateaus off. But I want to make sure you take home Robert's message, which is you need to look in the pot and you need to look at what tissue sample is sitting in your histology pot before you send it off. And if you're getting negative results and you're not getting the results you're expecting, you need to talk to your pathologist, and maybe you're just not sending adequate tissue, and maybe your pathologist just needs that little bit more. So just take that into consideration. I'm briefly going to touch upon ROSE. So there are 3 large randomized trials that show there is no difference in diagnostic yield when ROSE is used and when it's not. But I just want to show you a slightly different perspective here. These are 60 patients who had a combined procedure with EBUS and diagnostic bronchoscopy. And the final diagnosis, 49 of those 60 patients had granulomas. Now, they didn't perform ROSE. They did the full procedure, then they did ROSE afterwards. And in 43 patients, that would have confirmed granulomas there and then in the room. So what that is telling you is that 43 patients didn't need a diagnostic bronchoscopy because, in fact, you had the diagnosis made on ROSE. That will save time. And in this trial, they had moderate bleeding, and 1 in 10 had a pneumothorax. So you have to take that into consideration. But I will caveat that with one thing. So, of course, you may be suspecting tuberculosis as well. And so performing a lavage may be important in these patients, especially where you're thinking about infection. So EBUS in sarcoid is safe and would be your first port of call for diagnosis. Remember, negative results not always going to be reassuring. And whilst there is an improvement in the diagnostic yield in stage 2 sarcoid by adding diagnostic bronchoscopy, there are risks attached to that as well. We shouldn't be using conventional TBNA. And I think ROSE probably does have a role in non-malignant disease in particular, and because it will probably shorten the time that we're in the procedure room, because once you have that diagnosis confirmed, you can stop your procedure. So, TB. This is one of the first studies to look at the performance of EBUS in TB. So this was 150 patients. Their final diagnosis was lymph node TB. And this was then a sort of a flow chart that looked at all of the data. So these 150 patients, they had a pathological diagnosis made with caseation or necrosis, which would all suggest TB. But importantly, to look at 1/3 of them didn't have caseation. So there's always that question, isn't there, with is it sarcoid versus TB? Now, all of these patients will have had pathology sent, but we send for every patient a culture result for TB as well. And you can see here that patients will then subsequently culture tuberculosis. Now, when we combine the pathological and the microbiological outcomes, EBUS has a sensitivity of 94%. So really, really good when we're looking at diagnosing lymph node TB. One thing to note is that only about half the patients in this study cultured TB, and that probably reflects actually that there's probably a low bacillary load in lymph node TB. Now, can we make things even more accurate? So this was the St. Mary's group who were evaluating TB PCR in patients who had TB lymphadenitis. So these were 84 patients who all were culture positive. And what you can see is that 14 of them were smear positive on the results. Those 71 patients that were smear negative, the TB PCR, the gene expert probe, in 2/3 of them gave a positive answer. And what that means is that those patients can go on to treatment much, much quicker rather than waiting for the culture results. So for patients who have isolated mediastinal lymph nodes where there is a high suspicion of tuberculosis, we will send a TB PCR for every patient, as well as the acid-fast bacilli culture results. Great. So we're in the clinic. We've seen a patient who's had isolated mediastinal lymph nodes. You've performed an EBUS. It's negative. What's your approach? So click in your answers. Do you watch them? Do you keep them in your clinic and bring them back for a repeat scan? Are you happy the EBUS is negative and send them home? Do you repeat your EBUS? Or do you send them to a surgeon to do a mediastinoscopy or a thoracic or a VATS and a surgical biopsy? So everyone's saying, by the looks of this, clinical and radiological follow-up, and I'll definitely agree with that, but I would just want to highlight a few things for you, which is just important for you to consider when you're sitting in your clinic with that. So this was the Remedy trial. So again, from Neal at UCH, this essentially is a trial that looked at patients who had isolated mediastinal lymph nodes, consecutive patients that came through the clinic and were referred for who were then referred for an EBUS. If the EBUS did not give an answer, they then had a mediastinoscopy. And if the mediastinoscopy didn't give an answer, they were kept under radiological follow-up. And I'll come to the results in a moment, in fact. So what I wanted to just highlight, and really important for you to take into consideration, one, look at the lymph node size here. I don't have the scale, but in this study, a lot of the patients have large lymph nodes of more than 20 millimeters. Look at the age range. Patients are 42, median range of 42. And the sort of group of patients that UCH cover, you can see that most of them are non-white British. And I think that's really important to take into consideration as we go and look at the results. So 77 patients were submitted for EBUS and TBNA, and a diagnosis was made in 67 of them, showing you actually how accurate EBUS is for non-malignant disease, but also for cancer, because you can see whilst most of the patients had a diagnosis of sarcoid and TB, 2 had lymphoma, 4 had an extrathoracic cancer, and 3 had lung cancer. Now, of those 77, 10 did not get a diagnosis. They all had a mediastinoscopy, and mediastinoscopy picked up an additional 6 different diagnoses, including 2 with one with lung cancer and 1 with lymphoma. And the remainder had benign lymph nodes. And I just want to draw your attention to this. So this is really important. So the patients with reactive lymph nodes, they're only 5%. So the prevalence of reactive lymphadenopathy was very, very low in this group. So the EBUS performance, looking at all the data together, 92% sensitivity for making a diagnosis. And we know from various studies that is around exactly what the results should be. Importantly, prevented mediastinoscopy in this case, and of course mediastinoscopy so rarely done, we would be sending our patients for an EBUS for these sorts of cases. What I want to draw your attention to is that prevalence of benign lymph nodes was quite low in this study. And what that means is that the negative predictive value is also low. It means that if we took a sample and it was negative, we're not necessarily going to believe that that is a genuinely, truly negative result. And then you have your options of radiological clinical follow-up and potentially an option of repeating an EBUS or a further invasive biopsy. And this conclusions from this trial just highlight that. Now, I just want to turn your attention to other studies which have also looked at the performance of EBUS in isolated mediastinal and hilar lymph nodes. So this is from the Canadian group, Yasufuku. Look at their prevalence of reactive lymphocytosis. So 30%, 1/3 of them had reactive lymph nodes. What that means is that they can be a lot more confident and their negative predictive value higher. So they know that when they have a negative result, it probably will be a truly negative result. And they would be probably more comfortable with keeping those patients on the clinical and radiological follow-up rather than doing a repeat biopsy. So what's your normal practice after? Well, all of these are actually all very reasonable, and these are all dependent on your patient population and the prevalence of disease that you have. In the Remedy trial that Neal did, all the patients came from a very, very specialized MDTs, TBNDTs, ILD MDTs. The patients were young, non-British, large lymph nodes, in whom you would expect that they are most likely to have some pathology rather than having a reactive lymph node. In the trial done by Yasufuku, and in fact there's a Manchester trial as well, and if you had an older patient with COPD who recently had an infection, and you've got small lymph nodes, let's say of 10 millimeters, and you've done an EBUS and it's negative, you're probably more likely to believe that that is a genuinely, truly negative result. So I just want to highlight the importance of picking out these negative predictive values and evaluating them really carefully in your practice and in the patients you see with isolated mediastinal lymph nodes. So in summary, EBUS is safe, it's highly sensitive, it should be your initial investigation for isolated mediastinal lymph nodes. Do consider diagnostic bronchoscopy where you are thinking infection, because you may need to take washes or a lavage. There's always going to be that conundrum of granulomas. Is it sarcoid and is it versus TB? And so think about ancillary testing. In particular, remember that the culture rate for tuberculous lymphadenitis might be lower than you expect. And definitely follow up your patients who have a negative EBUS result and consider further investigation if you're suspicious. Thank you.
Ricky, thank you very much. And Robert, thank you. Fantastic talks. So we're going to move on now to the second recorded case, and then we will have time again at the end of that for some questions. So please do submit some questions for us to discuss at the end of this case, but let's roll the video.
Okay, thanks very much, Neil. So this is our second case, called case 3, because we happened to record 3 cases that day, but it is as a second case. And I'll just let it run through. And right at the end, you'll see that we did something else as well as the TBNA. We took another approach to try and make a diagnosis here. But I'll let it run and then we'll talk about it afterwards.
This final case is a 90-year-old gentleman who, despite his age, remains very fit and active. He can walk about 2.5 miles and he regularly plays golf. He had a persistent cough, was treated with antibiotics by his GP, but the cough persisted, went on to have a chest x-ray, which was abnormal, leading to a CT. And we'll take you through the imaging in just a moment.
And this is case 3. So same again, got the PET on the left and the staging CT on the right. And on the staging CT, we can see that they've got this right upper lobe lesion, again, quite heterogeneous. But on the PET, this is hugely avid throughout the lesion. On the staging CT, we can see that he's got small bilateral pleural effusions and his heart is enlarged. Again, he's got biatrial dilatation, and we can see that he's got previous coronary stents and quite heavy coronary calcification. And on the PET, these little pleural effusions are resolved, which shows that they're due to heart failure, and that he's had that treated in between. The node that we'll be looking at particularly tomorrow is this one here, which is precarinal. So that would be 4R, because here's the azygos coming in, and we can see it's just starting here. It does have quite normal nodal architecture on the CT, so it has a fatty center. This may be related to heart failure rather than the tumor, and that's why it's important that we stage it with the EBUS.
Okay, so this is the next case we're going to do, and that you heard about earlier. So we're just going to intubate the patient. Here I'm just looking, this is our standard 260 scope, so just intubating here through the mouth guard, over the top of the tongue, and past the uvula, and then down. Sometimes you lose your vision for a bit, and you've just got to gently push the scope down, and then you come out on the other side, as it were. There's the epiglottis. There's the chords there. Yep. Often if you can't see anything, it's because you're too too high and you're up behind the back of the tongue, and I've learned with time just to keep pushing in, and eventually the epiglottis will pop into view. So he's had a cricothyroid injection already, as well as 1 milligram of midazolam. He's having a good old snooze with 1 milligram of midazolam. There are the vocal cords moving. Is the left cord moving? Well done. So I'm just trying to get a better look at the vocal cords, because I got the impression that the left cord wasn't moving. There's no reason why the left cord shouldn't be moving, according to what we know about his scans, but and he certainly doesn't have a hoarse voice. So I presume it was just a little artifactual. Now I've lost my view. Is moving. Okay, that's fine. So there's the view as you go through the cords. There's the cricothyroid injection mark, and into the proximal trachea. Lignocaine in, please. Thank you very much. And then just slide down the trachea, keeping the scope nice and straight. Because with the offset viewing, you tend to see the anterior wall rather than the posterior wall as the trachealis muscle at the back. And we get down here. Note that I'm not sucking out the secretions at the moment because we're putting lignocaine in. Just pop in there. And I want the lignocaine to mix. I don't want to suck it all out again. something that people often do. Just pop one in the left there, please. Fantastic, thank you. So we'll just let all that anaesthetic take effect for a moment or two. Can I just have the bed up a little bit, please? That's lovely, thank you. I've got a nice SATS trace anyway, so. Lovely, okay, so we're going to start off. So we've got this lesion in the posterior segment of the right upper lobe. So I'm going to start off by having a look down the left-hand side. Left main bronchus. So I'm just going to take these secretions out as we go. A little bit of saline down there, please. Yeah, please, and again. That's better. That's better. So we've got the left upper lobe there in the lingula, up at the top, and the lower lobe below. And that all looks nice and clean. If we go in too far, we'll lose our imaging, so we have to inspect from a bit of a distance. There's the apical lower on the left, which you can normally turn and just get a squint into. That all looks fine. And then we'll go back and have a quick look on the right. And this looks a bit erythematous. At the top there, that's the right upper lobe orifice, and it looks a bit erythematous on that superior roof there. I'll just have some. Yeah, thanks. Just going to go down into the bronchus intermedius. Can I have a lignocaine in there, please? Thank you. There's the middle lobe and the lower lobe. Middle lobe there, lower lobe with apical lower. And if you can see on the view of me in the room, you'll see I'm turning around, so I move quite a lot. I don't just stand at the head of the bed, I rotate round the patient, keeping the scope reasonably straight, keeping my right hand up in front of my chest rather than twisting my hand around. It's much better to move your hand as little as possible. And then let's just have a look at here in the right upper lobe. There is the anterior and posterior segments. I suspect the apical comes off the anterior. Okay. Yes, okay, fine. Can I have ultrasound, please? Okay, so with ultrasound, we're going to start on the left-hand side, and we're going to run down into the left lower lobe, down here. and just put a little bit of balloon up there, just to improve my contact. And we're going to start having a look around, systematic look around at the lymph nodes. And the first port of call is the 11L node. See if we can see anything in here. Sometimes they're very small and not very evident. Some pulmonary vasculature here, branches of the pulmonary artery or pulmonary vein. Not seeing any obvious nodes down here. In this region, you can see the pleural reflection there behind the vessels with the lung beyond it, down towards the bottom of the picture. The lung parenchyma of the ultrasound picture is poor because of the air in the lung. And then if I come up, I'm going to come up, there's the upper lobe lingula. I'm just going to go onto the lateral wall of the left main. There's the pulmonary artery. And, then coming up from the pulmonary artery, coming up into the 4L space. Here, small lymph node there with a fatty center. Looks like it's got a fatty center. You can see the white fat in the center of the node. This gentleman is known to have a little bit of heart failure at times on his scans. We can see some small bilateral pleural effusions, and of course that will cause mediastinal and hilar lymph nodes to enlarge and change in size depending on his fluid balance. Nothing too concerning there in the 4L space. Then coming up here, you can see the aorta. And there's the aorta, probably the esophagus at the top of the picture there, just beside another small lymph node measuring about 3 millimeters short axis. And then the aorta here. And you can see the calcium in the posterior wall of the aorta. And then coming up here above the aorta, back up into the 2R, 2L space, above the aorta. There's the great vessels coming off the top of the aorta. This is now 2L. I'm just swinging gently backwards and forwards, slowly, looking for any lymph nodes. There's nothing obvious there at all. You can see in the endobronchial view here how high I am. Often makes you cough. You can see I'm quite high up above, almost going to extubate the patient, so you don't want to come up too high because it makes the patient cough. So I run back down again, and again just into the left side. This time I'm going to go in upside down so I can go in and look at the subcarinal space. And here's the subcarinal space from the left main. Looking for any subcarinal lymph node, station 7. Often in this area you also get the esophagus sort of jostling in amongst as well, so I think that's some nodal material there. It's not very well defined. It's quite, yeah, that's esophagus, yeah. You're going to put the cursor on. The cursor. So this is the esophagus here. You can see it all sort of moving around constantly. So that's all esophagus. And there's a lymph node, I think, just beside it there, yeah, where Alana's got the cursor now. There's a rather indistinct lymph node sitting in there, which is polygonal. It doesn't look terribly exciting. It's got some fat in it there. It's probably a normal lymph node in the station 7 position. Now I'm just going to flick over into the right side and have a look at the station 7 from the right. We tend to look at it from both sides. There's a lymph node there at the top. It's about 5 millimeters in short axis. It's fairly longitudinal, like a long, thin rugby ball. Again, not terribly significant looking, but we just note it for the time being. So that's station 7. So we're now going to look around the right-hand side. And we're just going to run down here to just below the right upper lobe takeoff. Just here. And just have a look at what we can see. There's a lymph node material there. Yeah, there's a lymph node there. That's 11R. That's just below the right upper lobe takeoff, 11R. Here, yeah. So there's definitely a node in there. Yeah. And then we're just going to come up above the right upper lobe takeoff. And here we've got the azygos vein there, I think. Yeah, there's the azygos vein there. Now, if I just turn, you can see where I'm standing at the side of the patient. I just look posteriorly to confirm this is definitely the azygos vein. You can see the pleura reflection behind the azygos with the lung beyond it. So I'm now looking posteriorly back towards the spine. So that's the azygos wrapping around the right side of the trachea. I'm just turning anteriorly again, and there's a small node there. And you've got the azygos vein, this node, and then another vessel there, which is the superior pulmonary vein. And that is a 10R lymph node sitting just in there between the azygos and the superior pulmonary vein, just in there, where Alana's got the cursor currently. So that's a 10R node. And then above the azygos vein, which is here, you can just see the azygos vein there dipping down and joining the SVC at the confluence. That's quite a nice image there, just there. So I'm now above the azygos, so this area will be station 4R. And sometimes the 10R and 4R nodes often almost bump into each other around the azygos vein, as they are doing here. So you can just see the azygos on the left-hand side of the picture. Now that node there is technically just above the azygos, but I suspect it's all part and parcel of the node I've just shown you. And then these are 4R nodes just lying anterior to the SVC. As I come up here, higher up. So we've got nothing significant in 11L or 10L, small node in 4L, which I think is normal. He's got some lymph nodes in station 7, and then in 11R, 10R, and this one that's sort of round the front of the 4R around the front of the azygos. So I think we'll sample. We'll start with station 7, and then we'll go and do the 4R node, and then we'll go down to the 11R and the 10R nodes. So we're just going to measure up now with the needle, which has already been prepared by Alana and colleagues. And we're just putting down the measuring up, so the needle's going down now. And Alana's just adjusting the sheath length. Do you agree with those notes? Good. You happy, Anna? Right, so we were going to look at the station 7 from the right, I think was the best view, if I remember correctly. There it is, that node there. We're just bringing the needle, getting the node in position there, bringing the needle down into the node. There we go. So it's all about lining the node up underneath the needle. I know what the trajectory of the needle will be. I know where to put the node, and you just bring the needle down onto the wall of the airway, make sure the node is lined up, and then pop through the airway into the node. And I've just got to keep the node underneath the needle like that. I think we'll just do one good pass in this node, and then we'll move on, as we've got quite a lot to do. And I'm just conscious of here the patient's tolerance for the procedure. He is a 90-year-old gentleman. He's tolerating it all very well at the moment. Okay, happy with that? We'll just check we've got a good sample. That looks like a good sample coming into the pot there. You can see it. Yeah, happy with that? Okay. There you can just see the needle puncture mark just there on the right side of the carina where I've put the needle in, or Alana put the needle in. This gentleman has been on warfarin, but his INR is being reduced to 1.27 today. And so now we're going to go for this 4R lymph nodes. So using the same needle, we're doing N2 lymph nodes first, followed by N1 nodes. Okay. So I'm going to go back and find my friend the azygos vein in order to make sure we've got landmarks. So I'm just going to check there's the right upper lobe. So just above the right upper lobe. Yeah, I might tolerate it better sitting up slightly. That's fine. Okay, so there's the azygos. Again, that's the azygos. And that's the 10R node, and then he had some nodes, just a cluster of nodes just sitting in here, there, that one there. That's the one I want to go for. Someone going to get a Lana. Yeah, this one right on top of the azygos, I think. That one, yeah, that's the one. This one node is sitting right anterior to the azygos, so it's right on the border between 10R and the 4R, actually. Okay.
Big swallow for me, big swallow. Okay.
I think put the needle in and I'll find the node, okay? They've got very fatty centers, these nodes, actually. Okay, there. Yeah, the one on the right, that one. That's the 4R one, that one. There we are, we're in it. That's the 4R node, and the 10R one's the next door to it. And the azygos veins behind. Quite tricky anatomy in this case, actually. Always makes it a bit more interesting just to sort out these lymph nodes. That one. That's it there, that one.
Anything in the back of your throat, just swallow. Big swallow.
Okay, we're in it. Nicely there. That's right, you can see Alana getting right across the width of that node. It's only about 5 or 6 millimeters. Fatty center, it's probably a normal node. Okay, great. Shall I do the 10R next? All right, well done, sir. You're doing great. He's in sinus rhythm now, actually. He's gone into sinus rhythm. That one there. So this is the 10R node now between the, there's the azygos popping in and out. There's a lot of respiratory excursion and So it's taking me quite a lot of effort to keep things stable for Alana to get that needle in to that 10R node, which she looks like she's absolutely nailed. Fantastic. Nice example of a biopsying between the azygos vein and the superior pulmonary vein there to a 10R node. It is a fairly triangular looking node with a fatty center, but I suspect it's going to be a normal node. I expect all these nodes are actually going to be normal, which will be good for the patient. But we just need to check. There was, let's say, some low-grade FDG avidity in them. High. Yeah. Yeah, these are heart failure. These nodes are probably in keeping with these heart failure, aren't they? Okay, right side. 11R, right upper lobe. Now we're going down to 11R. There's the right upper lobe, just a little bit of, just below it in here, looking for the 11R nodes. There it is, just there. Jumping around all over the place. There, yeah, that's it. That's lung coming through, isn't it, in the way there? Airway wall, you're just got to slow this through. Okay, take the needle out then. Can you take the whole thing out? Lost. There's the upper lobe. There's the 11R area. Fluid in the bronchus. Is that right? Okay. There's the node. Yep, you're in it. There you are. You're just on the edge of it. There, yeah.
So hopefully the audience can hear me, and we've, as you can see there, we're just sampling this 11R node. And then after that, I thought that it's likely that all these nodes were likely to be negative for malignancy, but we wanted to try and get a tissue diagnosis. So what we then moved on to do was to do a bronchial brushing through the EBUS scope, which I'm going to just skip the video on and just show you that, if you just bear with me.
Can I have a brush to the posterior segment of the right upper lobe appears to lead to this tumour. There's the posterior segment of the right upper lobe. You can just see it. And sometimes you can feed using this scope, you can feed a brush in. Well, so Alana, can you feed? Yeah. So just bring it back so it's just inside the airway. That's fine. Right. Hold it at the mouth, can you? You hold it at the mouth. Okay. That's fine. There we go, into it. Right, push the brush out. Someone else push the brush out. Alana, hold, don't let go at the mouth, okay? Okay, right, push the brush out. That's it, and wiggle it. Okay. No, don't do wiggle. I wiggle here. You keep the brush out. That's lovely. Well done. Okay, now pull the brush back in. Brush back. Good. Well done. Yeah, you can see I'm absolutely in the right place. Nice one. Okay, that's fine. Let's see what we got. Just rinse that. Can you rinse it in the... You can see there it's bleeding from the posterior segment where I've been in, just there. No. There it is. Okay, bring it back so it's just inside. That's perfect. And then, okay, feed it slowly. Okay, you hold it at the mouth for me. That's lovely. That's all right. That's all right. That's fine. Right, hold it at the mouth. That's it. Oh, it's gone in. Oh, that's great. It's gone well in now. Right, brush out.
Brush out.
No, that's brush in, isn't it? Is that brush out? Okay. Okay, brush in.
Okay, that's the end of that case. And I thought I'd just tell you a little bit about the outcomes of it. So that gentleman, as we said at the outset, was 90 years old. He'd actually tolerated the procedure incredibly well. He was very keen that we undertake the procedure. It was technically quite a challenging procedure to do. He had an ejection fraction of about 15 to 20% actually, which is why I was in a degree of heart failure at the outset. But the samples we took from the lymph nodes from station 7, 4R, and the hilar nodes on the ipsilateral side, 10R and 11R, were actually all negative for malignancy. But the brushings we did at the end showed a poorly differentiated non-small cell and small cell, so a mixed tumor on the cytology with neuroendocrine differentiation. And when it was decided that he wasn't going to be suitable for surgery given his poor cardiac function. Although I said functionally he was very good and still playing 9 holes of golf once or twice a week and able to walk a couple of miles. So he's actually surprisingly good. But he was seen by the oncologist, and actually he's having radiotherapy to his primary lesion. It was decided he wouldn't be suitable for chemoradiotherapy, but he's having radiotherapy. And the important thing there was that the hilar lymph nodes, the 10R and 11R nodes, were all negative. So the oncologists were fairly happy to give him radiotherapy to his primary tumor, if not to cure it, at least to try and prolong his life, given his good performance status. So that's the end of that case. I hope it's interesting just showing you the brushing at the end. You can also put down bronchial biopsy forceps and do bronchial biopsies through the EBUS scope if you need to as well, which we sometimes do. And I'm going to hand back now to Neal for the next Q&A session.
Thank you very much, Robert. That was fantastic work. Obviously, a very challenging case, beautifully handled. So we've got a couple of questions come in, so thank you for those. Do feel free to put some more in. I've made a few notes myself, and I'll ask some as well if we have time. First question, Robert, perhaps you could take this one first. Is EBUS alone adequate to rule out lymphoma? How can we increase our diagnostic confidence when using EBUS for lymphoma?
Yeah, so EBUS for lymphoma is always challenging. And when we do cases, so it rather depends on your practice. And it might be that you are, biopsying indeterminate mediastinal lymphadenopathy that comes back as a lymphoma. That's one scenario. The scenario I'm often in my practice is that we have patients who, it looks like they're likely to have a lymphoma based on the radiological appearances, the age of the patients, and so on and so forth. When we do, we usually talk to the lymphoma team in advance and to the lymphoma pathologists to make sure that we're going to get the right sample. So obviously with lymphoma, depending on the cell type, and there are many different cell types, Hodgkin's disease, you may or may not, it's not easy always with the EBUS samples. Sometimes you need core biopsies. Nodular sclerosing Hodgkin's, again, can be very challenging because the nodes can be very hard. So we tend to use larger gauge needles. We tend to do multiple passes and sample different areas. If that doesn't work, we sometimes have to go on to doing a core biopsy, percutaneous core biopsy, or a surgical biopsy. But I generally, when I get a lymphoma case coming along or looks like a lymphoma, I don't just rush into doing an EBUS. I always ask the question, what is the best test to do for the patient?
Thanks, Robert. Ricky, do you want to add to that?
Yeah, absolutely. I echo everything Robert has said, and lymphoma can be a bit of a tricky one when it comes to EBUS. So I guess there's a few things, obviously speaking to your hematopathologist is important because, for lymphoma, it's not, there's a number of things that matter. So the morphology, the immunophenotyping, but also the tissue architecture is also incredibly important. So the pathologist needs to be able to see all of that. There's one systematic review out there that that shows that the sensitivity is around sort of 66%, but it's really heterogeneous. And there are a few things that come out. So doing a EBUS in someone for suspected recurrence of lymphoma, you're probably more likely to get an answer than when you're looking for a de novo diagnosis. If there isn't really much out there with needle size, I don't think, and potentially the 19 gauge needle might be a little bit better. And talking to your pathologist again is important because those institutions that have flow cytometry in addition to histology, actually their yields are a lot better than doing histology alone. And I suspect rows and the addition of rows is probably better. But I think you have to take some of the studies with a pinch of salt, and you have to really look at what they're saying. So there are some that report sensitivities of around 90%. But actually, when you look at their definition of what is a positive diagnosis, they include patients who also need a confirmatory surgical biopsy into their results. And so you have to be really cautious about that. But I think, as Robert said, speaking to your hematologist and your hematopathologist is probably quite important. But from my perspective, I think for either, whether it's de novo, suspected or recurrence, if they've got mediastinal disease, I think EBUS, it would be a perfectly reasonable first test. It's perfectly safe to do that.
Thanks, Ricky. What about the mini forceps biopsies? What do you think about those?
Yeah, so there's a lot of new technology, isn't there, coming out? So there's putting mini forceps biopsies down into an EBUS scope and taking larger tissue samples. And as I said, architecture of the node is quite important, and certainly a mini forceps biopsy may provide a better information on that. And there are also very, very novel things happening. So there are some institutions who are also using an electrocautery knife to cut a sort of a small hole in the airway and then use a cryoprobe to take even larger biopsy samples. I think we need to wait and see what the literature will say on those.
Thank you. Perfect. Robert, what liquid media would you recommend for processing? I saw that you were using Cytolite, I think.
Yes. So that's a really useful question, actually. And I'm glad someone's asked that, because we haven't really talked much about pathology. To do EBUS successfully and well with good outcomes, it really is a team effort with your as well as the operator, with the radiologists, looking at scans beforehand, preparing your case. I should actually thank my excellent nursing team who are in the room with us for those two cases, led by Anna Festino and her team, because you want a good, experienced team around you. Who know the equipment, know how to handle everything. And the pathologists are a critical part. They may not be in the room, but when you start doing EBUS, you really want to go and talk to and engage your pathology team. I can't emphasize that enough. When we started doing it back in 2000, well, I guess in Edinburgh when I started doing it in about 2002, 2003, back then they were doing everything with glass slides and smears on slides and looking at dozens and dozens of slides. And then as time has moved on, we now use these thin preparations, and now we use a media called Cytolite, which is the one in the bottles, which is a form of fixative. Some places use formalin, but generally the pathologists, what they do now in many centres is they treat these samples almost like a histology sample. So they are on mini cores, although they are still designated, strictly speaking, as being a cytology specimen. But what they do is they spin the sample down into a pellet, and then they resuspend that pellet into the fixative. Well, it's in a fixative medium, so it's been fixed, and then they process it like a histology sample in paraffin, and then do cuts through it for the H&Es and the immunohistochemistry, rather than doing dozens and dozens of glass smears. And that has dramatically improved the diagnostic yield from the pathology point of view. And when I started doing all this, as I said, I suppose now pushing 20 years ago, actually, when we did the very first cases, we worked a lot very closely with the pathologists to try and optimize the results. And in fact, the pathologists now do discuss it among themselves quite a lot. And certainly if you are in a centre starting to do EBUS and your pathologists are not familiar with these samples, then what I recommend is for them to talk to pathologists in the centres that are doing a lot of EBUS and find out how they prepare their samples, because you can be the best operator in the world and get great samples, but if the pathologists aren't on board and aren't processing your samples optimally, then your results are not going to be as good.
Fantastic, Robert. Thank you. Ricky, is there anything you want to add from a pathology perspective?
No, I think Robert's covered everything on there. We use formalin as our fixative, but I think the key message is to talk to your pathologist and see how they want the EBUS samples and how they're going to process them.
Fantastic. Robert, we saw you doing a brush at the end of the second case this morning. How often do you do that? And I think the particular issue there is when the tumour's not visible endobronchially.
Yeah, so if it's not visible endobronchially, so often if you have endovisible tumor, so when we used to do bronchoscopies with a standard flexible bronchoscope and normal bronchoscope, and you sort of got a cauliflower, as it were, in the airway, and you do bronchial biopsies, and you get a fair bit of bleeding often with those. What we quite often do now, if we see one of those on a CT and we know what we're going to see when we go down there from the high quality CT in advance, actually rather than put down a standard bronchoscope and do that, we actually put down the EBUS scope and actually just put the probe on the tumor mass and then just run a needle into it. Because if you do that, you get deeper into the mass, you get past all that necrotic, sloughy stuff on the top, and you actually get usually minimal bleeding compared with tearing pieces of the tumor off. So we rarely do endobronchial biopsies now for endobronchial tumors. For the brushing, in that case, we had obviously this elderly chap with poor heart function. I could see on the CT he had the posterior segment of the right upper lobe airway ran into it. So I thought, well, actually, if I don't see anything endobronchially or on ultrasound, which obviously we weren't, I just try a brush and push the brush in as far as I can and see if I can get to it, which obviously we did, which was great, because that, he was very keen, this gentleman, to achieve a tissue diagnosis. And I didn't really want to have to put him through a CT guided biopsy. So actually that worked really well in that particular case. So we do it from time to time, again, on a case-by-case basis, looking at each case individually and saying, what are the things that we require to do for this patient.
Robert, do you do a bronchoscopy with a standard flexible bronchoscope to visualize the airway as well?
No.
And would you do that
Not anymore.
before or after?
Used to when we started, when we were using the early days prototype scopes and the early generation scopes where the endobronchial imaging wasn't as good. And we used to do a standard bronchoscopy and then intubate the patient with an EBUS scope. But of course, it's 2 intubations. But now I think with the advent of, I'm talking about over a period of nearly 20 years now doing this, which seems like an awfully long time. The standard of your CTs are so good now, and with reconstructions and potentially virtual, as Neal showed in his talk, that actually you get a huge amount of information from your CT beforehand. So you kind of know what you're going to see. It's, unless you are looking for dysplasia and subtle things like that in the airway, we now don't do standard bronchoscopies beforehand. We just go down with the EBUS scope, have a look around the airway, make sure there's no surprises, as I showed you in those 2 cases, and then get on with the EBUS.
Ricky, what are your thoughts on this, doing a bronchoscopy at the same sitting as an EBUS scope? What about if there's a lung lesion that might be sort of in the middle third or even outer third?
Yeah, I thought that's what you might ask, because the second part of that question does say with no visible tumour, doesn't it? And it's interesting because I think, as you know, our practice is changing as time goes. But just to go back to what Robert said, I think it depends on your patient. So if we have, let's say, a 2 centimetre mass in the periphery of the lung and, a 20 millimetre lymph node, which is really PET avid, we know we're going to get our result from the EBUS. Then I don't think there is any need at that point to be going in and trying to sample the peripheral lesion. But we will do a staging procedure, and we know, based on the probability of looking at the CT and the PET beforehand, that actually that we know that the lymph nodes will be negative. Now, thinking about the patient who will be either going into having surgery or stereotactic radiotherapy, in particular surgery, where often we want a pathological diagnosis because we want to avoid things like a benign resection, the way we approach bronchoscopy has changed. So we would now do a staging EBUS, and then we would use an ultra-thin bronchoscope and access the peripheral lesion under fluoroscopy, and using radial EBUS, take tissue samples either with forceps, depending on whether there's a bronchus going straight into the tumour, or using a transbronchial needle aspiration. And I think that landscape is coming, and that's will be coming, I think, in bronchoscopy over the next sort of 5-10 years. I haven't sort of spoken about robotic bronchoscopy at all.
I think the other thing, it rather depends what you've got in your centre. And, like you, we've got radial EBUS, and we sometimes do radial EBUS, but or percutaneous biopsies for the very peripheral lesions. Especially the smaller ones, because I think radial EBUS is good for the larger ones, but as your lesion size comes down, your sensitivity for radial EBUS comes down as well. The other thing to say is that the new generation 290 Olympus EBUS scope, the thinner one, does allow you to get out further. And we've discovered using it that actually if you push it out and just keep going down into the middle lobe and lower lobes, you can get out a surprisingly long way, and sometimes getting out to mid-zone parenchymal tumours that you couldn't previously reach with a 260 scope. And I've done one or two where I've been quite surprised, and you're just going down and suddenly, oh, there's the mass, suddenly looms into view on the ultrasound, and we just do a standard EBUS TBNA into it. So I think, as you're right, that the landscape is changing very rapidly, and it's to some extent also influenced by what you've got in your centre and your expertise.
Thank you very much. Yeah, I think this is obviously not about peripheral bronchoscopy, but I do think that is something as bronchoscopists we're going to have to get more involved with. In the UK, I echo what you say, Robert, about sampling sort of middle zone lesions, particularly in the lower lobes. I still think the upper lobes, it's not really possible to do that with even the 290 EBUS scopes, and hopefully the future iterations will allow that to occur further. As Ricky says, we do often sample peripheral lung lesions at the same time as mediastinal lymph nodes. I think it's a fairly attractive proposal, I think, to be sampling the lung primary and doing a lymph node staging procedure at the same sitting.
You also have sorry.
I was going to say we've had a little bit of recent success with using cone beam CT, and I think whilst that's not going to be available in every centre, I do think engaging with radiology colleagues can be useful, because many of them will have access to cone beam CT. And I do think that is something that while we're waiting for robotic bronchoscopy in Europe, that I think that is something that might improve peripheral bronchoscopy significantly.
Can I ask you a question? Do you think that I know at UCLH you have patients with you're often under propofol sedation, and I'm not sure if they're intubated fully or you haven't used laryngeal masks and so on. Do you think that approach facilitates doing multiple procedures like a linear EBUS followed by a peripheral ultra-thin navigation type approach, as opposed to the setup we have in Cambridge, actually you saw there, where actually you've kind of got one eye on the clock for the sake of the patient who's under moderate sedation?
Yeah, no, thanks, Robert. Obviously, always got one eye on the clock, but yes, we do have the advantage of propofol, and I think it's the biggest change that we've made to our bronchoscopy service over the last sort of 10 years or so. when previously we had one list a week that had propofol support. We now, for all 7 lists, we have propofol based sedation. So patients are self-ventilating. They have a standard mouth guard in. We use Optiflow, high flow nasal oxygen. And for selected cases, so perhaps larger patients or people in whom a little bit more complex, we do use a laryngeal mask airway as well, typically an eye gel. And yes, when required, we do place a flexible ET tube as well if we need to. So I think it does give that flexibility. I would suggest it's hugely cost effective. About 10 years ago, we tried to run a prospective study to try and have a look at the potential benefits to patients and operators of propofol versus non-propofol based sedation. That was called Lung Sedate, and we started, but we quickly stopped just because we just felt it wasn't really appropriate to continue. And I would always prefer to do my cases with propofol sedation. That is the standard for vast majority of procedures around the world, and I would encourage colleagues around the country to engage with their anaesthetic teams and see what support might be available to them. Great, we've strayed slightly off topic, but hopefully interesting discussion. There's one more question here on the slides. What about needle size? Ricky, do you want to?
Yeah, of course. Yeah, so this is a really interesting question. It's a really good question, actually, because we have different needle sizes. So we've talked about, I briefly talked about the 19 gauge needle before, which is very flexible. We have 22, and it goes down to 25 gauge needles. Now, as I said, there isn't really any evidence at the moment to say choosing a bigger needle is going to necessarily improve your diagnostic yield, but probably the 19 gauge needle in non-malignant disease will help. There is also an advantage for using the smaller 25 gauge needles. So sometimes there will be those lymph nodes which are just tucked in at an angle. In particular, sometimes the high superior mediastinal lymph nodes, which despite having your thumb fully down, you can't quite oppose the scope all the way to the airway wall. And actually, sometimes that is going to be in part affected by the needle. So when you have a 22 gauge needle and you're trying to get that to visualize your lymph node, if you can't, sometimes changing down to a 25 gauge needle might just allow you to have that little bit of extra flexion, which will allow you to see the lymph node and sample it more accurately.
Thanks, Ricky. Robert, your thoughts on needle size?
No, I think I entirely agree with those points. I mean, we generally, for most of our work, we use 21 or 22 gauge needles. Those are our workhorse needles, as it were. And there are various needles available from different manufacturers. In fact, there are the Olympus needles, obviously, that go with the scopes, but there are various other manufacturers that make needles that are compatible with the Olympus scope and with the other scopes from other manufacturers as well. Some of them require adapters to be put on. But again, I would suggest to people that they try some of these different needles and, go with what works for them and what they feel comfortable with. I think, as with, any procedure, if you're happy with the tools you're using and confident in their use, then, your outcomes will be better.
Thanks, Robert. Our standard needle use is a 22 gauge needle and then 19 gauge needle in selected cases. Great. So I had a few, just in the last couple of minutes, I just had a couple of questions that I might pose to Ricky and Robert. Tell me about, and Ricky, you touched upon Rose in your benign disease talk. Maybe I could get your views on Rose in patients with suspected lung cancer.
Yeah, absolutely. So, as I said, and this also applies for lung cancer, in that the rows in sort of randomized trials, in prospective trials, haven't shown a difference in diagnostic yield. So having rows necessarily doesn't pick up any more cancer than whether you have rows or not. I think, well, it does have a role though. So in shortening the procedure time. So, Robert talked about a lymph node that he was, he might be very suspicious of. Instead of doing 2 passes, he might do 3 or 4. But actually, if you had rows, then if your first pass had cancer cells in there, you can be confident and leave it there. I think the other place rows will have a real impact on, and going back to sort of the previous discussion about sort of sampling the peripheral lesion as well, is actually once the staging procedure is complete and you're happy that you don't, that's all negative on rows, then actually that will prompt you to potentially move on to sampling the peripheral lesion. And certainly for peripheral lesions, I think having rows is going to be invaluable.
Thanks, Ricky. So we used to have rows, rapid on-site evaluation at UCLH, and then our pathologists felt they had better things to do. Robert, what's your experience been of rows? Have you used it in the past? Do you think it has a role?
I haven't actually counted the number of cases I've done over the last years, but it's probably quite a lot now. And I have had rows for one case ever. We did in Edinburgh in the very, very early days. And like you, our pathologists feel that their time is better employed elsewhere. I have been present in bronchoscopy rooms where rows is used, certainly in Europe when doing courses like this. The other thing you have to bear in mind is the preparation time. So we were doing a course where the operator was in the room doing the case, and I was sort of standing there observing actually in that case, and the cytopathology technician was in the next room, and the sample was taken, went through to the cytopathology technician who did their stuff, but it was taking between 5 and 10 minutes for each sample to actually get reported and come back. And in the meantime, the operator was standing there sort of twiddling their thumbs or taking some more passes, by which time I would have done all the passes I needed and just moved on. So I think that is another factor, the time factor. I think there are a number of things, but if you can persuade your cytopathologists, given there is a national shortage of cardiothoracic pathologists currently, if you can persuade them to come in and do rows with you, you are lucky.
And I've found it, I do recall when starting off, I found it very useful for our learning curve, actually.
Yeah.
Even if you could persuade your pathology colleagues to join just for the short term, whilst the service was kicking off or whilst a new operator was beginning, that may be something that can be very helpful. My final question is something we haven't quite covered properly, I think, which is complications. Ricky, what sort of complications should people be looking out for from EBUS?
So I think the really important thing is that EBUS is safe, and in having major serious complications are rare. So the unusual rare things that we hear of are things like mediastinitis, sometimes pneumothoraces, and these happen in sort of 1 in thousands of cases. So it's very, very unusual to see a serious complication from EBUS. There are some things that do happen, and that's happened in my practice certainly, and other physicians that I know, and sometimes you put your needle out and you do get bleeding. And I think this is something to be really aware of. And so if there is sort of brisk bleeding, you've got your normal things that you can use, cold saline, topical adrenaline, that would help. And sometimes just having the scope pressed up against the airway wall, just where you've done the puncture, can sometimes just help settle that bleeding down. Otherwise, Neal, we rarely see complications from EBUS.
Robert, what are your thoughts about complications?
Again, it depends how you classify complications, obviously. And, those that are life-threatening are extremely rare. Although I have had one patient die after a procedure in my career, and that was due to infection. A patient who had an undiagnosed streptococcal throat infection and became septic 24 hours after what was otherwise a completely unremarkable procedure. And sadly died of sepsis. That was many years ago now, but I always remember that case. So these very rare unexpected complications do happen. Then there are the sort of, complications like, pneumothorax and so on. As it happened, we made a pneumothorax in a patient earlier this week, but we were doing multiple biopsies into a parenchymal lung lesion, and it's recognized that sometimes happens, not very often. Bleeding is, occasionally, but not very much. I can't remember when I last had to use adrenaline on an EBUS case. So, I think generally it is a lot safer and has fewer complications than many of the other endobronchial procedures we used to do, such as standard bronchoscopy with biopsying endobronchial tumours with forceps, where you could get torrential bleeding sometimes, or transbronchial biopsies, where you can also get heavy bleeding sometimes. So generally very safe, but obviously always be aware. And it's sometimes the cases where you really do not expect anything to go wrong that catch you out. So you always have to be very vigilant.
Thank you very much. Great. Okay. Well, I think we can bring the discussion and today's webinar to a close. I'd very much like to thank Robert and Ricky for their time and expertise, particularly Robert for the fantastic cases as well, and the videos that we've watched. Thank you also to colleagues from the IT side of things online who have been fantastic setting up this webinar, and of course colleagues at Olympus, Richard, Kerry and others who have helped who have been instrumental in providing this course. The recording will be available on the Olympus platform for the next 30 days, I think, and there are 5 golden CPD points available. So please do watch it in its entirety if you didn't get a chance to watch everything this morning. Please also do give us your feedback. This is, I think, the second time now we've done this in virtual format. We'd be really grateful for your feedback on things that you think we can improve on. And thank you very much for attending, and enjoy the rest of your day. Bye for now.